All right, welcome to everyone to the webinar on social inequalities in health in the EU. This morning, it's great to see so many people here. It's very nice also to see that people are still coming in. We already have over 100 participants, and it's nice to have you here. So my name is Caroline Costongs, and I'm the director of EuroHealthNet. And we are really proud to be able to launch our flagship report. Here it is on social inequalities in the EU. And this was written by our team together with Chain. And Chain is the Center of Health Equity Analytics at NTNU in Norway. Yesterday, we had the in-person lounge. We had a lounge in the European Parliament. We were present in the Sant Committee, which is the Public Health Committee, and we were there together with Professor Sir Michael Marmot, and we had, I think, a very good pitch to the members of Parliament of the Sant Committee. And also in the afternoon, we had a high-level debate with various stakeholders at the interest group on health inequalities, risk factors and prevention of the Parliament, which is led by Vytenis Andriukaitis, MEP. Persistent and widening health inequalities are really a sign that our societies are not doing well. And we find it important to take this message to the politicians. They need to be made aware that we do not only talk about improving health of vulnerable groups or marginalized groups, which you hear politicians often say, which is really, really important we do that. But our message is very much that we talk about health of a much larger group. It's across the socioeconomic gradient that we see worrying signals and where we need to see action. So that's one important message that we conveyed. And the second important message, particularly for the members of the Sant Committee, which is in public health, is that they need to be more aware of the root causes and act on the root causes as well. The time flew yesterday, as always, so we are delighted to have now the webinar with all of you here. We have 2 more hours to dive a bit more into the detail of the research and also to look more at the country level and what can be done. Well, how is the data looking like in the countries and what are potential solutions that we can take? I think we have an exciting agenda. We will start with the presentations to look into the findings of the report, and then we have a panel discussion on our policy recommendations and proposed actions. And then we have a breakout session in 4 countries, and we end with a final reflections from Professor Sir Michael Marmot. I hope we do have time for you to ask your questions. Please, you can you can put them in the chat, or you can raise your hand, and I can see if we have the time available for you to address them live here. Right, let's start. And I would like to introduce to you Dr. Mirza Balai. She is a project.
Caroline?
Yes.
Mirza seems to have left a meeting. I don't see her.
All right.
There may be a technical issue on her side.
Yes. So then I suggest we start with Ingrid, because the report that we did was very much close cooperation. So we had Dr. Mirza Balai, and she is a project leader at Chain. But Ingrid Stegeman is a program manager at EuroHealthNet and authored actually the whole report. And Ingrid and Mirza, they both worked really hard over the past months. And Ingrid can start maybe with.
I see Mirza has arrived now.
Okay.
Mirza, can you turn on your camera?
So let's see if Mirza is ready.
Yeah, but can you hear me?
Yes, we can hear you.
Yeah, institutional restart of the computer, so it just did it at 10:05. Apologies for that.
Oh.
If someone can share my slides, Semina has them. I can present them.
All right. Okay. Computers always.
I will share them, Mirza.
All right.
So you can do your intro again, Caroline.
All right, well, here we are. We see Mirza. And thanks a lot, Mirza, for all the hard work and on the data of the European Social Survey. I mean, there's a lot of work that you did with the team at Chain. You're now based at the University of Maastricht, which is also a member of EuroHealthNet, like Chain. And yes, I suggest that you start, Mirza.
Thank you very much, Caroline. It's been an amazing journey to be able to look at all the data, the new round that came out recently from European Social Survey, and to be able to write this report, to dwell on the data, and to see also trends, how the health of Europeans has actually changed over the past decade. So I'm, as Caroline presented, I'm Mirza Baley. I'm a project leader now at the University of Maastricht, and been working on this project together with Ingrid and the whole EuroHealthNet team. And so altogether, we are able to share this impressive array of results, which are actually possible only through the European Social Survey, which, for those of you who don't know, it's a survey that is going on in Europe since 2002. And it's a biannual survey where rotating modules on top of the core questionnaires can be included. And we were able to include two of them, one in 2014 and one in 2024, and ask Europeans, over 40,000 of them in both rounds across 30 countries, questions regarding their exposures to material determinants, occupational determinants, psychosocial determinants, but also lifestyle, and to relate those exposures and risk factors to chronic diseases. In our report, we focus on only 14 European countries from the European Union member states, plus Norway, Switzerland, and the UK, because these are the only countries that were present in both data collections. If we looking at the results, the first health measure we focused was poor self-reported health. So what we know is that still in 2024, 1/3 of the population across Europe reported poor health. This is not a change, unfortunately, from 10 years ago. It's quite stable, really a 1.8% improvement altogether. And large differences continue to persist between countries. So we have Irish reporting 17% overall of poor health, and up to 48% of Lithuanians reporting poor health. Self-reported health has improved significantly in only 4 countries out of the 17 countries we studied, and these are Hungary, Poland, Portugal, and Slovenia. And unfortunately, it has decreased in 8 other countries, Belgium particularly, Finland, Sweden, United Kingdom, Norway, Lithuania, Ireland, and Spain. However, as we've been mentioning repeatedly, that we need to go beyond these averages and look how these health shifts have affected different socioeconomic groups in the countries. Here, we are looking at results for high education group. So how has the health changed for high educated in Europe in this last decade? On average, 20% of high educated Europeans report poor health, and this range from 13% in Austria to 30% in Spain. And we have in four countries that actually the health of higher educated has worsened significantly in the last 10 years, which are in the United Kingdom, in Sweden, in Ireland, and in Norway. And health gains have taken place among higher educated in 5 countries, in Hungary, Germany, Lithuania, Austria, and Slovenia. The health shifts for lower educated have also been important. However, they start from a very different level of health. 40% of Europeans with low education report poor health. We need also to be clear about the definition of poor health. It's like these are all people who report very, very bad health, and fair health. So when we say poor health, it's people who are not actually living up to their health potential of being good or very good. So it's suboptimal health that we are actually defining. And variations across countries are also quite staggering, like 27% of Irish with low education, 22% of Irish with low education report poor health, and that goes to 58% of low educated in Lithuania, considering their health as poor. There are significantly worse levels of health in 4 countries among the lower educated, particularly in Norway, in Belgium, in Austria, and the United Kingdom, compared to a decade ago. And large health gains have taken place among low educated only in 3 countries, in Poland, Slovenia, and Hungary. Trying to put these 2 pieces of information together, we have prepared this graph, which actually shows how the overall health has changed in the last decade, and at the same time, how health inequalities have shifted in the last decade. So in the green quadrant, in the first one, are countries who have been able to improve overall levels of health and also reduce social inequalities among educational groups. Further up on the left, on that quadrant, are countries who have made the largest reduction on health inequalities, and those are Poland and Slovenia, which means that not only overall their society is in a better health state, but that has accrued more rapidly among the lower socioeconomic group. On the right, on the left of the graph, we have plotted all countries that actually have lost levels of health over the last decade. Countries in the darker red area are countries who have not only lost health, but also have lost it at an equal pace among educational groups. So in particular in Belgium and in Norway, we have lower educated, which have disproportionately carried the burden of health loss compared to higher educated in the countries. Sweden and Ireland are highlighted in red because we really want to send across a strong message when we when we talk about changes to social inequalities in health. Because as you can see, in these countries, they fall in a quadrant where they have lost levels of health overall, but they have decreased inequalities among social groups. However, it's very important to go one step further and understand whether this decrease is actually a success, like are they improving anything among the lower educated, lower socioeconomic groups, or is actually a loss of advantage from socioeconomic groups that are usually more advantaged. And the case is the latter, like there is a reduction in inequality because higher socioeconomic groups are losing health rather than lower socioeconomic groups improving their health, which means that this does not, it's not progress in terms of social inequalities in health because there's no progress on the shoulders of any socioeconomic group losing their health benefits. Another health outcome that we focus extensively in our report is poor mental health. In poor mental health, we see that in 2024, 13% of the Europeans report poor mental health levels, and the shift has been very minor. Like there is quite some stability overall in terms of poor mental health. And the differences between countries are still persisting. Can you hear me?
Yes, I can hear you very well, but I think you have to go a bit faster on the mental health to also enable the other slides to be seen because time goes fast, Mirza.
Yeah, it's the same layout. So we did a similar analysis, and what we see is that the shifts are also across countries less significant. So we have only 3 countries which have actually significant improvements in mental health, Hungary, Poland, and Spain. And however, 3 other countries which have significant declines in overall levels of poor mental health, Belgium, UK, and Finland. Looking at how this has been distributed, this shifts in the burden of poor mental health across socioeconomic groups, we focus on occupation, and 8% of high occupation group report poor mental health. And across countries, we see a bit unexpectedly for us writing the report that high occupation group in many of European countries, they are losing their advantage. So they are reporting higher levels of poor health. And these are in Belgium, in Portugal, in Lithuania, United Kingdom, Norway, Finland, and Spain. Decreasing levels of mental health, on the other hand, for high occupation groups have taken place only in 3 countries, Austria, Hungary, and Poland. For the low occupation group, we have 17% reporting poor mental health. And again, improvements have taken place in 9 countries, and reduction in mental health in 8 countries. However, these are less significant shifts that we see, but there is a tendency for several countries, like they're on a positive trend for a lower burden of poor mental health for low occupation group. And plotted again, these overall changes in the population in terms of burden of mental health and distribution of mental health across occupational groups, we see that countries the minority are actually in a good track, which are the ones in the green quadrant. And among them, particularly, improvements have taken place in Spain, in Hungary, and in Slovenia. The countries in the darker red area are again countries in the most unequal path, meaning that losing overall levels of health while increasing the burden on the lower occupation group. So we thought of taking another step forward, especially from a policy perspective, and looked at the European Pillar of Social Rights, which is a framework to strengthen the social dimension of Europe, and they have a set of indicators to be able to measure how well countries are doing in their social investments. Among them, we looked specifically at employment rates, and our main proposal through this report is actually to move further in disaggregating this data. For instance, we see here in the employment rates over the past 10 years, like all countries have increased the employment rates, exception being to this trend only Lithuania. But who has benefited from more participation, being more active in the labor market? So in the next step, we disaggregated this data by level of education. And we see that in 10 countries, the education employment gap has decreased. So it means that we have some advancement there. And in 6 countries, actually it has increased. And particularly you see highlighted here that in Austria and in Norway, we have quite a substantial increase in educational inequalities in labor market participation. But there is also an equal opportunity in the labor market for men and women as one of the indicators of the scoreboard. So our next step was to disaggregate these trends both by education and gender. So I'll go quickly through this. What you see here is how employment rates have changed per education, and this is for low education. And what are the inequalities among the low educated between genders? So the red dot is showing 2024 data and the blue 2014. In 8 countries, the employment gender gap has increased, which means that among low educated, we have actually the benefit of being more active in the labor market compared to 10 years ago has mostly gone to men. And in 5 countries, the employment gender gap has actually decreased, meaning that women have been able to enter the labor market to a larger extent. The same for we see the same for the high educated. The shifts are more minor compared to the magnitude of these shifts compared to what happened to the lower educated. And we have among countries who have actually been able to improve participation in labor market for higher educated, which are all the countries you see on your right. We have 5 countries where the employment gender has increased. The employment gender gap has increased among high educated, which means more high educated men have actually benefited from access to the labor market, being active in the labor market in the last decade. But we have 7 countries where the employment gender gap has actually decreased. So more women have entered, high educated women have entered the labor market. So just quickly to go to the key takeaways. It's what we see is like particularly only one country has been able to improve both overall levels of health and mental health, while at the same time reducing social inequalities in those outcomes. Unfortunately, there is not much progress when it comes to overall levels of health. Most of the countries are stagnant or decreasing levels of overall health. And the good news is that there is some convergence. So countries who were worse off 10 years ago and had more room for improvement, they have done so. But at the same time, countries that were faring better 10 years ago are reporting lower levels of health, leading to a convergence in Europe to a lower level standard of health. High occupational groups, as we mentioned, are reporting higher levels of poor mental health, which is definitely sounding the alarm of how competitive also our society can be if even the most advantaged are under pressure. And some positive trends are for the low occupation groups in some countries, which it's actually very important also to examine further and to see what have been the levers that have improved their levels of mental health. One of them probably being also higher access to the labor market itself. So my last point is the social scoreboard is definitely a tool to help us build a stronger and social Europe, but it can only lead to that if we are able to look at more disaggregated data and examine who is actually benefiting from our social economic policies and who is being left behind and what should we do to carry everyone forward. Thank you.
Excellent, Mirza. Thanks a lot for this overview. I do not see any questions in the chat, but I can imagine that people do have questions. So I would like to ask you also, Mirza, whether you are available to stay on after this webinar for some 15 more minutes or so. So if you have some technical questions or you want things to be clarified, I invite you to stay on after the end of the webinar. We can have a short exchange on that. All right, I would like to now go to Ingrid. Ingrid Stegeman, Program Manager at EuroHealthNet. Ingrid, floor is yours. If you can unmute yourself, Ingrid.
And I'll just quickly pull up my presentation, but just to say it has been an amazing journey working on this to get such a comprehensive picture of now really understanding what is happening on health inequalities in the EU, since EuroHealthNet has been working on this for around 20 years, but in various forms. But this really gave us the opportunity to bring together this knowledge. And we've heard now about progress, or in many cases, the lack of progress that's been happening, at least in the last 10 years. But that leaves the question open as to what can be done to address this. Oh, I see I'm in presentation mode, I think. Can you see my slides?
Yes.
Okay.
We see your first
in
slide
mode. Okay, super. So that's what I'll focus on. Again, it's a very comprehensive report. This is just a quick overview of the content around what is being done, what can be done nationally and a little bit also at European level. But before jumping into that, I do think it's important to pause and think about how we conceptualize health, because I think we carry two parallel visions. One is the idea of health as the absence of disease or infirmity, and the other one is the more holistic conception as defined by WHO as well-being. And it is important because this affects what can be done and who can be involved and should be involved in improving health and its distribution. And in this respect, the work of the WHO Commission on the Social Determinants of Health, who came up with their final report in 2008 already, was very influential in promoting this more holistic conceptualization of and understanding of health and its distribution as an outcome of a very wide range of structural and societal factors. In our report, we also looked at, or the ESS survey asked about chronic disease, health problems and chronic conditions that people are suffering from. And we see that the situation is very much corresponds to the outcomes in general health inequalities, or general health outcomes, that many countries are seeing an increase in many chronic conditions, particularly in northern and eastern, northern and Northern and Western Europe, although there are improvements in Eastern Europe other than in Lithuania. And this is despite the fact that a lot of behavioral factors have improved. People are improving their health-related behaviors when it comes to, for example, smoking and alcohol use, although this isn't the case when it comes to healthy eating, because fewer people are, for example, consuming fruits and vegetables. But the reason for the increase in chronic diseases therefore lies in other underlying factors. And the ESS survey also asked, and the health module also asked about these, and they asked about, for example, problems growing up, housing problems, unpaid caregiving responsibilities. And you really see that in the last 10 years, there have been an increase in these kind of problems or drivers across Europe. And in the survey, we even dove further into trying to understand what these drivers were. The main outcome was that financial strain is really the most important factor associated with and for self-reported health and for self-reported mental health. And the factors differ slightly. For example, for self-reported mental health, occupational factors play a big role in driving poor health outcomes, while for self-reported health, factors like body mass index and financial difficulties during childhood played an important role as the underlying causes. Now, when we're looking at these underlying causes, we can it's clear that health systems can't in and of themselves, they don't have the ability to address all factors driving health inequalities. But they do play a very important role, and this role really rests in providing the evidence, as we're doing now, and raising awareness about these issues. And throughout the report, we asked our members to provide us with examples and case studies of what they're doing to address health inequalities. And some of these examples are very good, illustrate what they are doing in terms of providing the evidence to, for example, under the Public Health Act in Norway, to local and regional authorities around giving health profiles to them so that they can act on these underlying determinants. And in Hungary, for example, a new tool has been developed to really understand what's happening, which areas within the population in Hungary are deprived, so that, again, national and local, regional local governments can act on that. And then, of course, health systems have an enormously important role in making sure that in improving access to quality care. And Denmark is, for example, has developed a social vulnerability index that practitioners can use within health systems to identify people who are in more need, but in ways that are non-stigmatizing, and then in ways that they can then prescribe not just medicine, but also access to other social services. And then the role of health systems is also obviously to collaborate and provide this evidence to other sectors so that they can determine the best approaches forward. And here the Swiss and Slovak health program is really interesting because it's not being run, it's in collaboration with the Department of Health, but it's actually being managed by the Ministry of Investment and Regional Development, because that ministry has direct control over some of these enormously important drivers. So having the information and the evidence, it's very tempting to then target approaches to those areas and the people who are most vulnerable and deprived. But as Caroline explained at the outset, when we're targeting, you really you exclude a large proportion of the population across the gradient, health gradient, whom are not maybe doing are not the worst off, but that are nevertheless losing a lot of health potential. And targeting also risks, for example, having poor services, creating poor services for the poor, and it can be very inefficient when you're just targeting one issue while there are many other problems that are undermining those efforts. So in that respect, a proportionate universal approach is and taking this is much more important, which means resourcing and delivering services at a scale that is intensely with scale and intensity proportion to the degree of need. And this is a concept that has been developed by Professor Sir Michael Marmot, who will no doubt speak about this a little bit later, but it's an incredibly important concept when it comes to understanding what can be done to reduce health inequalities. Targeted approaches are, of course, still needed, for example, for groups like mothers and children, because given what we know about the importance of the early life years, and for certain population groups, like, for example, prisoners. We have a very nice case study from Finland around work they're doing in prisons, because often people there are there as a result of undiagnosed mental health issues, for example. But proportionate universal approach also, again, demonstrates that what's really needed to address health inequalities is a more holistic approach, whole of government approach. And this has also been in recent years really defined and is a growing body of work around the well-being economy, well-being approach, where it's looking at that looks at evaluating progress in a way that goes beyond just GDP and towards well-being. And there are nice examples of countries that are embracing this approach and working it in government. For example, in Wales with the Future Wellbeing Future Generation Act, Finland developed a national action plan for the well-being economy that integrates all different sectors. Fortunately, with a change of government, this is a bit less of a priority now, but they have really pioneered the concept. And SOSTE, the Finnish Federation for Social Affairs and Health, our member is also doing pioneering work in terms of looking at the genuine progress indicator and comparing this against GDP to show the limits of GDP. For example, while GDP is increasing, general progress really hasn't. That's more in line with our findings around health inequalities, that progress is very much has, in this case, declined and is stagnating. So the report also looks at what EU-level action to reduce health inequalities. I won't dwell on that here, but just to say that the EU is very well positioned to take a well-being approach. It would be very suited because in the EU treaties, the core aim of the EU is well-being, and a core value is equality. So that even beyond example, economic growth should be in the function of these larger core aims. And in this chapter, we go into the fact that, well, this is not really the case at EU level and subnational level, but there is progress being made in this area. So I encourage you to look at that chapter if you're, or section if you're interested in learning more. And then there are many the key important policy areas to look at to address the key drivers that we've been we discussed also at European level, but it's very important that these policies are developed in a more integrated, comprehensive manner that involves different policy sectors and not through siloed approaches. And this highlights the importance, particularly of governance mechanisms to reduce health inequalities, because it's through these mechanisms that it enables breaking silos, maximizing win-wins, managing trade-off, different sectors, that ensuring that they can manage trade-offs between different policy priorities. And it also highlights the importance of distributional and impact assessments. This goes against the grain of simplification, which is an important buzzword at EU level now, but it does lead to more effective policies and more impactful policies, particularly when it comes to social progress. And in turn, this does require more data, more monitoring, more disaggregated data, but to feed the evidence of how we can get more effective policies. So in summary, what can be done to reduce health inequalities, social inequalities in health? Well, it's understanding that all sectors contribute to this, and that it's a very important, health inequalities in themselves. All sectors prioritize this as a very important indicator of how well societies are delivering well-being. It's important to invest in research to uncover the root causes and to guide effective action, and to strengthen funding and capacity of health systems to play their role, and particularly their role also in working across systems. So for this, we need more health-promoting health systems and to invest in these accordingly. And we need to integrate health equity into all policies through governance tools like the European semester at EU level. So that was a very quick run through and summary of what can be done. But again, it's all in a very comprehensive report that brings it all together.
Super. So thanks a lot, Ingrid. And the same for you also here. If you can stay after the webinar in case people have questions, then we can address them then. So thanks a lot for your great overview, and thanks again also to Mirza. The report has a wealth of data, and it's really important to show the evidence to policymakers or those empowered to make decisions. But sometimes the best evidence comes from personal stories. And I'm really delighted to introduce to you Dominic Waters. He is a poverty expert and he has lived experience himself. So I hope Dominic is here with us in the webinar. Maybe we can close the PowerPoint.
Yeah.
Ingrid? Yes, great. And I see Dominic as well. Hey, hello, nice to see you. And
hey, great to be here.
Yes, and I would like to give the floor to you for your reflections, Dominic. Please go ahead.
Thank you so much. And yeah, it is great to be here. And there was a recent article with the whole team from EuroHealthNet on me speaking about my journey and my positionality, but I'll just briefly introduce myself. So I'm a single dad. I've raised my daughter in the most deprived blocks of our council estate, which I understand in European terms is called social housing. Well, in England, we call it a council estate. And the shop on my estate, it only sells like the lowest quality of processed food and nothing fresh. So like here, our access to nutrition is just overlooked. And I would never kind of have the I guess confidence, but because of the stigma and the snobbery that definitely exists in English society, before Marcus Rashford and his work about raising and giving more rather than just about free school meals, more giving a kind of validation to the voice of the poor, I wouldn't speak about any of the things we go through to anyone outside my council estate or social housing. And yeah, just to say, and not to mention like names or name drop or whatever they call it, but I very recently said to Jamie Oliver, the famous chef guy, that like on my estate, you can get blueberry vodka you can get mango bubblegum vapes, but not for £1 million could you get actual blueberries or mangoes in my council estate. And that really resonated with Jamie. And yeah, hopefully he's going to be funding some of my work moving forward. And on another level, and like I remember literally standing where I'm sitting now with my daughter next to me, and we were looking out the window because I'm speaking from my council estate block. And it was the first time we've lived here for like in this council estate, which ironically is a food desert in the Garden of England, as I've written about. And actually, as Sir Michael Marmot quoted my piece on it, saying that he was moved by my description. But we stood here, me and my daughter, for the first time we saw politicians, the local politicians, canvassing the area and canvassing the estate. For 19 years, we've never seen that. This is about 3 years ago, and we saw them walk down the road, the MP and her team, and they got to the corner and they looked at our blocks, the blocks where I speak to you from now, which are visually deprived. And me and my daughter watched them turn their back on us, on my whole community, and walk back up because we weren't even worth investing the time in canvassing. So I think that like that experience, one, sharing that with my daughter brings whole nother levels to it. But I'm trying to express that we speak from a kind of a forgotten about space and a forgotten about people, and also forgotten about feelings. And I think that does speak to the kind of unrest, that there's a connection to the unrest that is as I understand Europe wide, but I can definitely speak to England and the UK. There's two things I've done to try and kind of challenge or tackle these inequalities. Actually, there's a lot more, but two main things I can think of now. And I started a concept and a community interest company called Food is Care, which is trying to really kind of gather finances to be able to not have people speak about us that doesn't like include us. So my work is like, unlike a lot of other well-meaning organizations, my work is actually for the community, but from the community, which gives it a much deeper understanding of the inequalities that we face. And yeah, I started a GoFundMe on that, just to plug it quickly if anyone wanted to support my work, because there needs to be finances to somehow begin to make a difference in this location. Another thing I've done is I've redefined or reimagined with a visual 4 pillars of food insecurity. So my redefinition is just 4 photos that I've taken.
Yes, somehow you got unmuted, Dominic. I don't know why. Maybe if you can unmute again. Computer does weird things sometimes. Yes.
Okay, no way.
Here you are.
So yeah, I hope you can hear me. So yeah, I've redefined visually food insecurity with 4 photos from my council estate or social housing environment. And these are just 4 photos that I took on my iPhone, and I've purposefully not included any photos of fresh food to highlight the lack of access that my community experience. And each photo actually speaks to like a bigger structural inequality, from, a photo of our block with the disrepair from, I don't know if I can quickly share. Would that be to give a visual?
Yeah, if you manage to get that done, yeah. We don't have much time, unfortunately, as you know, Dominic. But
I'll leave it for now, but you can check it out on my website, or I'll chuck it in the chat. But it's different different inequalities that we experience, from a lack of access to transport, so a bus that doesn't show up, making it hard to even get out of where we are, the disrepair of our housing, the inconsistent gas and electric connection that we have as pay-as-you-go customers. I think people in England would definitely understand that, and also the shop. And so a couple of things I'll just leave you with is around, like, I hadn't heard, so I'm currently writing a paper to try and impact policy and academics on their approach to working with communities like mine, to hopefully build a deeper understanding of what it is that we go through. And through my journey moving into academia, I'd never heard of the concept around an obesogenic environment. I hope I said that correctly. And it was from learning that, and I won't say any names out of respect for all my neighbors, but from that, I started critically looking at my 4 blocks. So they're 4 identical blocks that we live in. I live in the second one, and noticing how many of my neighbors are visually obese is disproportionate than you would see on a middle or upper class street in England and Europe wide. So 2 things to leave you with is around, also I work with a campaign, Health Equals, that Sir Michael Marmot is involved with as well, and it's quoted that it's been found that if you come from one of my blocks, that your life expectancy is 12 years less than if you're from the more affluent areas just a couple miles down the road, which shows that about how poor people's lives don't really matter. I'm also involved on a national picture and policy picture on trying to help inform in England, we have the National Food Strategy. So I'm grateful, and I should say this, I'm very grateful through partnerships like this with EuroHealthNet to be able to give a voice to people that are generally just unheard. And one of the ways that I'm making communities like mine heard is speaking up as part of the National Food Strategy on their advisory board. And I'll just welcome anyone who wants to kind of follow me or check me out, DominicWaters.com. Thank you guys so much.
Super. Thanks a lot, Dominic, for sharing with us your experiences and for explaining poverty to us. I think we have to learn so much more, and we are delighted to be able to do more with you as well. We have indeed an article in the EuroHealthNet magazine with an interview from us with you. So the link is shared. Also, I see many comments from the audience really appreciating you sharing your story with us. And thanks again, and we stay in touch. Thanks, Dominic.
Thank you so much, Anne.
Right, so I think it's clear from the report, but also the account from Dominic, that there is a lot to do, and that we haven't been able to turn the tide on the widening health inequalities, and that the future looks, even more bland, maybe. So yes, we have to work, and we now enter the panel session where we look into what can be done. And we have a range of policy recommendations on the root causes and also more on the governance mechanisms. And I would like to actually start with Sylvia Ganzela. She's our program manager, and she organized the session in the European Parliament yesterday, where we collected views from a diverse range of stakeholders. And I've asked Sylvia to share with us some of the outcomes of the learnings that we got from yesterday, Sylvia. So we can maybe start with that. Floor is yours.
Yes, thank you very much, Caroline. So now we move from the personal local level, we jump to the macro European level. Our idea was that this excellent report from EuroHealthNet and Chain, that is so rich with data information going beyond the statistics, really looking at the granular and breaking down data across different dimensions, was worth to be communicated to policymakers at European level. And one of the biggest strengths of this report is not to provide some key messages on the trends. Health is not getting better in Europe. Health inequalities is not getting better in Europe. Mental health is not getting better in Europe. And clearly this is going against European values of social inclusion, of social cohesion, as well as being competitive and be an affluent country. But the report also identifies the key drivers of this issue. And the key drivers, it's not a surprise for us that we are an expert, but policymakers, they tend to work in their silo. And we really want to get different sectors at the same table to listen to us, to listen to these key drivers, and then to start to think about what they should do as policymakers. So we had people from European Commission, from social employment sector, engaging with the Commission from health sector, which I think it was a big success because they always tell us they coordinate, but I think there's also some improvements. Then we had a member of the European Parliament from different parties that are actually engaging with this interest group that we also contributed to set up on health inequalities, promotion and risk factors. And that was the first event that we organized in the Parliament with this, excuse my voice, interest group. We also had some other European institutions, such as the Committee of the Region, that brought also an interesting element of importance of looking at regional level, city level, and there was also a call to look at disaggregated data at regional and local level, which was an excellent recommendation, but it takes a lot of extra work, but clearly this is something we can also consider. And then we also wanted to have a bit of a critical voice from trade unions, and then we invited at the table representatives from civil society, from health, from social and researcher. And I thought that the outcome was great because there was an agreement that we need European solution. We need to look long term. We need to work more, break the silos and work together across different sectors, but also across different levels of governance. And it was also the opportunity for us to reflect with the stakeholders on the key policy dossiers that are coming out at European level. That will be our next steps, because this process of trying to create this coalition at European level working on health equity is a long-term process, but we do have something coming up immediately. We have a new EU anti-poverty strategy coming up, and this is part of a cluster of strengthening the pillar of social rights, especially the principle 16 on access to healthcare is written in the pillar, but we are saying you have to look outside healthcare sector if you want to achieve your objective. So now we have an opportunity to make sure that in the European anti-poverty strategy, these wider drivers that have an impact on health inequalities will be captured, because once they are in a European strategy, then it's easy to say we need policy, we need funding, we need to do some actions about that. Do I have to stop? Okay, very quickly, I will also mention that there's a European plan for affordable housing and the cardiovascular health plan. And these are some of our immediate actions for the moment.
Thanks, Sylvia. Thanks a lot for setting that out so clearly. Sorry I had to stop you, but we have other people in the panel as well. Thanks, Sylvia. I'm delighted to have on our webinar also Chris Brown. Chris is the head of the WHO European Office for Investment for Health, the Venice office, and you have been working really hard already many years ago on the first health equity status report, and you are about to launch the second one. Yesterday we heard some insights already from Dr. Hans Kluge, who is in New York, but I'm happy to have you here, and I would like to give you the floor to share your insights and what we can expect to see. Chris.
Okay, thanks, Caroline. I'm just checking that everybody can hear me.
Yes.
Just to say, congratulations on the report. We need data like this, but more than that, we need dialogue, and we need people like Dominic, the lived experience, the real people to be all at the table. And I guess that kind of highlights what's behind our report that we'll be launching in December this year. We cover 53 countries using 7 different types of data over 20 years, looking at status and trends. And I'm probably not going to say very much more about that, more than focus on what are we going to be saying about the way we can work together to change lives and recreate a new social contract for health, because basically that's what we're talking about. How are we creating a new social contract for health? We first of all need to look at financing. We need to finance just and healthy transitions. We have a lot of policies. We're in an extremely difficult fiscal space, both locally, nationally, at the European level. So just seeing what policies need to be invested in without actually saying how we're going to find.
I'm afraid that we lost Chris. I mean, I certainly lost her. So she must have.
She seems to have disappeared.
Yes. So I suggest then we go to Terje, and once Chris manages to get back, then we give her the floor again. I'm sorry about this. So Terje. Hi, Terje Eikemo. Professor Terje Eikemo is the leader actually of CHAIN, of the Center for Health Equity Analytics at NTNU. And I would like to give the floor to you now for your additions.
Can I just say that I was just
there you are.
I was just removed from the meeting by, I think, somebody who's playing around with the
okay, all right.
So I'd like to continue if you don't mind.
Yes, please. So Terje, see you later. Yes.
Okay.
Yes.
So
great.
Sorry about that. Thanks.
And
Caroline.
I also hear someone typing. Yeah.
Yeah. Can everybody mute their mics if they're
yes.
not? So on the just and financing for health equity, we will be launching this year in December a new publication on how to fund just and fair transitions. We'll be launching an event. We'll be bringing finance, economy, health, and bankers together with investors who are committed to this. There is $1.3 trillion in the market for social, economic, and environmental investment. And we are bringing them together because health, improving health, not particularly health systems, but creating better lives for today's generation and the next, is at the heart of that investment. So we will be establishing a impact investment alliance for health equity and well-being to ensure that countries who want to tackle equity will be connected to investors who want to fund that. This will also support the post-2027 multi-financing framework and partnership plans and investments at the European level. In line with that, working within countries, we are finding that central banks are really concerned about what's happening about the demographics and trends in society from a fiscal stability point of view, as well as ministries of social affairs from a democracy point of view. So under that, we're working with 6 countries, central banks, finance, economy, health, under the Finding Common Ground initiative, to develop new modelling by which central banks can routinely incorporate health and equity in their projections and in their advice to governments, ministries of finance and economy, so that health is brought in there from the beginning. Secondly, I think Dominic mentioned this somewhat. I think mistakes that we've been making in the past with our evidence is that we then go to design policies for people falling behind rather than with them. And our report will show two things, that social isolation and loneliness and exclusion are combining with every other form of inequity that we have. And that's across the social gradient. So first of all, what that means for health services, we need to address not just the clinical and medical, but also the social and interpersonal aspects. So the way we design our services have got to actually not just address the clinical needs and the health needs, but they've also got to address the social inclusion and the isolation needs. And we have some really great examples of that, say like the FROME project in the UK, which is a new model of primary healthcare, and the Caring Neighbourhoods initiative that we have in Belgium. You mentioned New York, where I was also earlier this week. So countries such as Slovenia, Iceland, France and Spain were with us there, committing to renewing the social contract through deliberative democracy and participation. Dominic said it very nicely. If we're not involved, how do you know what really are the reasons why the policies aren't working and what policies and services are going to work? So the lived experience and deliberative democracy are really crucial if we really want to accelerate health equity. Some nice examples of that are the UK Wigan deal, which was a whole dialogue with the community, business and civil society about creating the community they want. The Slovenian Law and Budget engaging civil society, Iceland's Economic Council, and France Sanitaire Démocratique. All these are great examples, and they're not just projects, they're institutionalized way of doing business. Secondly, we get fixated on certain policies. Our view is that there's no way that we will shift the deep-seated inequities they have with one intervention and with one policy. We need a basket of policies. And we know from our earlier work that if we use a basket of policies, such as labour market policies, health and social protection, and living condition policies, all together in a country of 80 million, we can improve the lives of 300,000 people in 4 years. So we would be bringing that forward, but how do countries know what the basket of policies that's right for them? In our study, we show that countries are very, very different in where they've had wins and losses for equity and health. So we're launching a health equity tracker, which will enable communities, governments, civil society to come together to say, these are the core basket of policies that would have the most effect in our country. That's backed up by Health Equity Atlas, providing all the data so countries can do their own analysis and look at what kind of policies and progress they're making. And then we're just about to launch a Health Equity Pathfinders Country Initiative, where countries who are committed to taking forward the recommendations of the report will act as live policy sites for implementation and share the learning with other countries. Lastly, but not least, I know, Caroline, I've maybe got 1 minute left. You're doing a great job to moderate. I know it's not easy. We have to take a life course approach. And our deep dive on the Health Equity Status Report, the second one to be launched in December, is taking a life course approach. We're seeing worrying trends in inequities in living with an illness in young people, 15 to 24. And we know that we need different strategies and policies there, as well as across the life course. We need to ensure also one other thing, that all of our policies, all of our interventions, all of our laws are gender responsive, because we're seeing massive differences and we're seeing that policies are not having the gender equity impact that we want. So we will be putting forward proposals for gender proofing and equity proofing policies. So thanks very much.
Excellent, Chris. You managed to put in a lot of recommendations and suggestions in your short intervention. Indeed, we need a new social contract for health. I very much like the Impact Investment Alliance that you are mentioning and looking at, okay, there's money out there, we know, and how can we make sure that it's invested in the things that are needed most? Very important. You mentioned social isolation, indeed, and involving people with lived experience, as we heard, is so important, and the life course approach. Very, very good. A lot to think about and take further. Thanks a lot, Chris. Yes, we go back to Terje Ekemo, the leader of Chain, who can share with us some recommendations regarding data and data monitoring and how we can improve our data on social inequalities and health. Terje, floor is yours.
Thank you, Caroline. Now, obviously, the kinds of discussions we've had here today and yesterday in the Parliament.
We don't hear you very well, Terje. Not sure how far the microphone is or if it can be turned up.
Hear me now? Better?
We can hear you, just maybe speak a bit louder. Maybe that helps.
Louder, okay. I'll try. Now, the kinds of discussions we had today so far and yesterday really require that we have access to excellent harmonized data across countries. And I would like to go to the 3 recommendations that we have provided in the report that highlights this. And I will try to dig a little bit deeper into this and share with you the challenges that we face, but also some exciting opportunities for the future, because the data landscape is about to change. And in some respects for the better. So I hope that you will listen carefully for what we can provide for the next few years. Now, the first recommendation we have in terms of data acquisition is that we need to improve the frequency and granularity of our data. And we also heard that yesterday. We need detailed data on both social determinants and health outcomes. So survey data, which the report consists of, are best suited to capture the social determinants, a broad set of social determinants from healthcare to lifestyles, occupational conditions, living conditions, and so forth, education. But mortality data, which is most commonly understood as being more granular, are the most reliable source for health outcomes, provided that they include information on causes of death. But both types of data are essential, and used together, they offer a complementary perspective that provides a fuller and more accurate picture of health inequalities. Now, over the past 2 days, you have seen the results of our report using survey data from the ESS. In addition, Chain currently manages the largest harmonized mortality database in Europe that is connecting causes of death to education. It is called the Erasmus Chain dataset and is developed together with Erasmus Medical Center in Rotterdam, which is a dataset that links death to education and other social factors. But this work is limited by several challenges, and they are known. It's about resources, so we need to invest. We need to invest in a large consortium, which we currently don't have. We have a consortium that is working regularly, but it does not have a long-term funding that can support this kind of work we need. This is a consortium that should include data sharing contacts in countries who can prepare and provide data on a regular basis. And it should also collect and harmonize data on cause-specific mortality and social determinants regularly. And this is only enabled through a large and steady consortium, which is possible to do. Now, there is another challenge as well. There is a variation of data quality and data availability. Not all European countries even collect information on causes of death and education. Can you imagine? Now, there is another challenge. There are costs and there are restrictions in terms of data sharing agreements, which there is a solution to. We can provide analysis and do them in the countries where they are stored. But of course, this is time consuming. There are costs associated. But if we want to have detailed data on a regular basis, we need investments in a European consortium of partners that can work together and produce regular reports in this area. Now, the second challenge is about children. Now, we heard yesterday that data on children, longitudinal data on children, is completely lacking. As I mentioned yesterday, now, most of our resources are devoted to studying adults. So if we are serious about protecting children and promoting their opportunities, especially in a digitalized world, increasingly so, we must invest in the longitudinal data source on children in a comparative way. And the European Commission has already invested in 4 large European Horizon projects the last 10 years to prepare such an initiative. And this has resulted in the preparation of the GUIDE study, Growing Up in Digital Europe. It is co-led by Gary Pollock from Manchester Metropolitan University and Janine Sloan from the University College Dublin. And in 2028, the GUIDE study will be ready to launch, a historic milestone. And I can tell you, it is going to be one of the largest research infrastructures in science. It will follow thousands of children in each participating country for 25 years. However, even though many countries have placed GUIDE on their roadmaps, only France, one country, has so far found children important enough for them to be studied. And nearly 30 countries are prepared to join, almost. But they need to secure funding for their national GUIDE teams. So supporting them would be one of the most valuable investments we can make, and one of the greatest responsibilities we hold for the generations to come. So if you listen to this as a policymaker, as a researcher, I encourage you to find out who is leading GUIDE in your country. You can reach out to me, to Gary, to Janine, to find out who this is and support them in implementing the study financially or academically. Lastly, and I'm going to be really brief because I said my main points. Now, regular reports on social inequalities in health and progress towards targets is something we need to do as well. And that is our 3rd recommendation in the report we have been presenting for 2 days. And this must be based on combinations of data, including harmonized survey data and mortality data, but we can also rely on systematic reviews and meta-analyses. And now I'm going to share something exciting. We can also rely on the global burden of the disease study. And you may wonder why, because there are no social determinants included in that study. Well, that's going to change, because Jane has been working with the GBD study very closely since 2018 to prepare low education as the first social risk factor in the global burden of disease study. And this will completely change our European and global understanding of the health benefits of education as compared to all other risk factors that are included in the GBD study. Now, by GBD 2025, that's in 2 years, we expect this to happen for all-cause mortality. And by GBD 2027, we expect to have causes of death also included. Now, regular European reports will have richer data sources by 2027, but we still need to combine these analyses with data from surveys like our health module and mortality registries, even given that resources are made available to this. And needless to say, Jane is prepared to continue to lead in this area together with our partners across Europe and beyond, and above all with EuroHealthNet. Thank you for your attention.
Great, thanks a lot, Terje. Thanks a lot for setting out the need that we need to have good data on social inequalities in health, the lack of data on children, and the exciting GUIDE study that you mentioned, and but also the issues with funding. Countries need to ensure they continue to fund data monitoring and data analysis. And the opportunities that there are with the global burden of disease study and to include an education indicator there. So fantastic work. Let's keep going on this together and with others, and ensure that we get the health inequalities monitoring done well. And isn't it also that you are part of the WHO global network or something on social inequalities data monitoring?
Yeah, this is true. So there is very new initiative that has started in 2025. The WHO has initiated something called the Health Inequality Monitoring Network,
Yes.
which is a new initiative that will monitor health inequalities and implement actions that can promote change worldwide. And so far, there are 12 institutions globally that are involved.
Great.
And in the future, there will be more opportunities for more institutions around the world to join. So please stay alert and follow this initiative. Fantastic initiative by the WHO.
Yeah, great to hear. Thanks a lot, Terje. Right, we now go to the country level and we go to Spain. We will have more in-depth analysis in our breakout sessions later, but we wanted to give the floor to Ana Gil Luciano. She is the head of health promotion and equity at the Spanish Ministry of Health. And we had wanted to give you the floor, Ana, as one example of how a country is dealing with social inequalities in health. Anna, floor is yours.
Thank you, Caroline, and thank you for the invitation. It is an honor, and of course, congratulations on the report, which highlights health inequities and helps us illustrate the reality, but it also highlights the complexity of its factors and its solutions. So, in Spain, we consider 4 main domains that we have to address when we work on equity. The first one, we have to tailor policies to the population needs. And in this sense, we have to advance in public health surveillance with an equity and a social determinants of health approach, which we are already developing since the pandemic. And we also have to take into account that equity has to be a cross-cutting and a fundamental part of every policy. We are not the Department of Equity, and the rest of the ministry is not. Equity is a responsibility of everyone, and working for the well-being of the population. So we have to really ensure that. And for example, for the health sector, we provide tools as, for example, the checklist to analyze equity that we will be presenting in one of the breakout sessions. And this type of tools, we think that it are useful to systematize equity along with capacity building. That it's essential to make equity a real part of every policy. Secondly, we find health and equity in all policies, which of course working together with all sectors involved in society is essential. We also find important to advance in health impact assessment with an equity approach, which is an important surname of health impact assessment. In Spain, we are also advancing in this sense. It's not being easy. We are advancing through developing methodologies and also developing legislation. But we think it's one of the tools that really help materialize the health and equity in all policies approach. And we also find like a third domain, which is addressing social determinants of health, already with this intersectional work, but also focusing on the causes of the causes. For example, our approach right now in our obesity strategy or in mental health is based on this social determinants of health approach, and going to these causes of the causes also, although it's a health problem. And focusing also on addressing commercial determinants of health, which we think it's vital to ensure not only health, but health equity. And the fourth domain would be social participation and community engagement. We already know that it's essential. There's scientific evidence that community engagement helps improve health and health inequalities. So we really think that it has to be a cross-cutting approach in all policies. In Spain, we're also trying to advance in this sense in these last years. Through community health and promoting health at local level and health promoting schools, with many interesting results, working with regions and with local entities, and because we think that participation has to be the closer it can be to where the people live. So it's really an important part of our lines of work. So we think that with these four domains in mind that obviously are interconnected, we must continue having equity in everyone's agenda and making it a reality. Thank you.
Thanks, Anna, for being so concise as well, and for highlighting indeed how in Spain you take health equity really at the core of the different policies and your efforts there. We can learn a lot from Spain. Thank you. And let's now move quickly to our final panelists. It's Raffaella Bucciardini. She is director of the National Center for Global Health at ISS, which is in Italian National Institute of Health. And Raffaella is also the leader of a work package on health inequalities in the very large joint action Prevent NCDs. And the joint action has several more years to go, and quite many countries are part of this. So if you could, in not too long, in a few minutes, explain to us what the actions are that you're doing. Raffaella, the floor is yours.
Thank you, Caroline. Thank you very much. Good morning, everyone. Yes, I am very glad to be here to talk about, as Caroline said, the Joint Action Prevent NCD, which started in January 2024. This joint action is not just a technical project, in my opinion. It is a way to bring equity into the prevention of non-communicable diseases. Together with more than 8 partners at 25 countries, we are collecting and reviewing what already exists. We have been doing, for example, umbrella reviews on cancer, diabetes, and on risk factors like smoking, alcohol, diet, and physical activities. We are also mapping data dashboards in some countries, and we have already identified more than 230 dashboards. But the problem is clear. Very often inequalities are hidden. If data are not divided by income, education, gender, migration background, we cannot see the real gaps. What is invisible cannot be solved. Another point for us very important that we are also reviewing what countries are already doing, the national and the European policies and the action to reduce inequalities in cancer and another non-communicable disease. Most action, for example, still focus on individual behavior, which is important but not enough. Much less attention is given to the social determinants of health, housing, work, environment, access to services. This is exactly where strong action is needed and where our joint action wants to give support. Another very important aspect in this joint action regarding the pilots action. Across the joint action, there are many pilots on different aspects of the prevention. In the work package that I coordinate, we have 22 pilots projects. They work in 3 different areas. For example, monitoring, that we hope to create better indicators in making inequalities visible. Health literacy, for example, in school, with migrants, or in vulnerable neighborhoods. On vulnerable groups is another important cluster for us, such as improving access to cancer screening, supporting migrants with help desk, on working with communities near polluted areas. These pilots are different in focus and in countries, but they all have the same goals to make prevention more adapted to people's social context, to reduce health gaps. Another very important part in this joint action regarding the health equity tool. It is a very practical resources. It guides partners step by step for planning to implementation and evaluation. This equity tool was provided for ISS group and also with some colleagues of the Sapienza and University of Turin at the beginning of this joint action. It help harmonize indicators, integrate equity dimension, and make results comparable across countries. So the message for me is simple. If we want prevention to work, we cannot stop at the behavior change. We must address the social determinants of health, and we must integrate equity in all policies. This joint action is helping us to do this by connecting evidence, policies, pilots, and the tools. It is a step towards more effective and fair prevention across Europe. Thank you very much, Caroline, and good. I think that this debate will be very productive. Thank you.
Thanks a lot, Raffaella, for setting out what's happening in the Joint Action Prevent NCDs on health inequalities, and we'll hear more about it in the years to come when the pilots are also going to deliver its results. Thanks a lot, and thanks to all the speakers of this panel session. It was really very rich in terms of content, and we didn't have so much time to further debate, but it's really happy to have you ahead on board. Now we are a bit later for the 4 breakout sessions, because it's very important to look what's happening within the different countries and also what the data tells us from our study. For example, we talk a lot about the higher and the lower income groups or education or occupational groups, but it's also very interesting what is happening in the middle, because in some countries we see that the large middle group, they improve together with the higher groups, but in other countries they do less good. So it's really we have to really look into what is happening in each country in order to be able to define what policies are best. And that's why we will have a more in-depth discussion in 4 countries. And David already shared with all of us the links, because we have specific links to go to your breakout sessions. So we have one session on Poland, one on Austria, one on Spain, and one on Norway. So you can pick the country you would like to listen into or to contribute to, and we'll have half-an-hour sessions.
Okay, slowly but surely we will start in the breakout session focusing on Austria today. I probably start slowly to allow people to still come into the room. But for those of you who are already there, again, apologies for a little bit of a short break. There's a lot of information to cover today. My name is Anne. I'm a program manager at EuroHealthNet, and I'm joined today for the presentations on Austria by our dear colleague Marion Weigel, who is head of the Health Society and Equity Department at the Austrian National Public Health Institute. The two of us will start with 2 very short presentations. My presentation will focus on the data from our EuroHealthNet chain report. And then Marion's presentation will focus a little bit more in detail on Frühe Hilfen, which is a program in Austria on early childhood interventions. And we want to show you some additional data coming from that program specifically. But so the data on Austria is particularly interesting, as you will see. Mirza has already very well explained that we covered health as well as mental health. So this first slide is the overview on the rates of poor self-reported health of 25, 75-year-olds. And you see that average levels in Europe, across Europe, range from 15.2% in Switzerland in 2024 to 47.5% in Lithuania. So Austria is highlighted here. You can see that Austria is therefore doing rather well. In 8 out of the 17 covered European countries, self-reported poor health has actually increased. But in Austria, we see a slight decrease in 2014. So 10 years ago, 21% reported self-reported poor health, and in 2024 this lowered to 20%. However, as we will see now, this apparent stability in the average is hiding a certain variance in depending on the social group that people are in. We have checked for the different education level and educational groups. So low education means lower than secondary or a lower secondary school completed. High education means bachelor or master's degree. And what you can see here is the blue line showing the data, the European Social Survey data from 2014, and the red line showing the new data from 2024. And here we can very well see low education to the left, high education to the right, and on the y-axis, the predicted probability of self-reported poor health. So mid-education and high education groups have actually managed to lower the probability of self-reported poor health. This is positive. However, the low education groups predicted probability has even further increased, thereby increasing the inequalities, the educational inequalities in Austria. The next graphic shows this even better. So the blue dots are the situation in 2014, and the pink dots are the situation in 2024. And you can see very clearly that Austria is the country with the worst increase of health inequalities in poor self-reported health, coming from a number below 1.8 to now nearly 3. What does that mean concretely? It means that people in the lower educated groups are nearly 3 times more likely to self-report poor health than people in the higher educated groups. And in total percentage points, it's in 2024, 38% of lower educated reported poor health compared to only 13% of higher educated people reporting poor health. We, as I said before, also covered mental health, and here the picture is a little bit different. Here we have numbers ranging from poor mental health from 7% in Norway in 2024 to 24% in Lithuania. Austria is here a little bit in the middle, let's say. And here as well, the poor mental health in Austria has decreased. So the orange bar covering 2024, as we can see, is has decreased, which is positive, from 10.8% in 2014 to 8.9%. So there is a slight decrease there. And unlike in health, here we can see that all different groups, here we haven't covered educational groups, but occupational groups. So from low occupation group to high occupation groups, meaning white collar groups. And like in the graphic before, you can see the blue line representing 2014, the red one is 2024. And the fact that the red line is constantly below a blue is a positive trend, meaning that the predicted probability of self-reported poor mental health is lower for everybody, all different groups. However, what we can also see is it's even better for mid-occupation and high occupation group. Low occupational groups have benefited less than the other groups from this trend. And in this, Austria is a little bit of an outsider of the 17 surveyed groups, because actually only 3 countries from the surveyed groups, meaning Hungary, Austria, and Poland, reported decreasing levels of poor mental health among higher occupational groups, because what we could see is a very worrying trend that in 7 of the surveyed countries, high occupation groups actually reported worse mental health, and in 7 other countries, the progress has stalled. So here, Austria, together with Hungary and Poland, is a little bit of a positive outsider, meaning they have improved mental health for all groups, including higher occupational groups. In comparison to the health, you see that here the differences in changes in relative risk of occupational inequalities in poor self-reported mental health is much smaller, but that the trend is negative. if we have 2014 to the left and the pink dot 2024 to the right, it still means that the occupational inequalities have increased. And in comparison with some other countries, we can see that in other countries, the pink dot is to the left, meaning that they at least have a positive trend. But Austria started from a rather low inequality, actually the lowest in 2014, as you can also see. But the situation has somewhat worsened in 2024. The people with a lower occupational background have a probability that is 1.8 times more likely of poor self-reported mental health in comparison to higher occupational groups. So to finish my presentation on the report, to summarize what I've already said, is we see that the overall levels of self-reported poor health are stable, but this average actually hides a strong redistribution of health across social groups, and the highest increase actually of inequalities in poor health among all surveyed countries, among all surveyed European countries. And we also see that self-reported poor mental health slightly improved for everyone, which is positive, but even more for higher occupational groups, thereby slightly increasing the inequalities. Thank you so much for your attention for this first presentation, and I'm happy to hand over to Marion.
Thank you, Anne. Can you see the presentation now? Okay.
Yes, I see it very well, thanks.
Thank you. So I have the pleasure to talk about the Austrian Early Childhood Intervention Program, which was developed on the basis of available evidence, experiences from implementation of similar approaches, needs assessment, and the stakeholder involvement in the years 2011 to 2014. The overall objective of our program is to improve the development and health prospects of children at an early stage and in a sustainable manner, with a specific but not exclusive focus on socioeconomically disadvantaged groups. It's a two-generation program supporting parents but with a focus on the children. This means to strengthen resources and reduce burdens of families in a way to ensure the parents have enough capacities and skills to promote the well-being and development of the children, and therefore can ensure a healthy upbringing, including strengthened skills needed later. In the long term, the program aims to promote health and social equity. So we're talking about a support based on individual needs of families in stressful situations, organized as regional networks. The core elements are family supporters working as home visitors with the families and network managers, ensuring the cooperation with a broad variety of professionals and organizations from different sectors. I want to point out that the program is free of charge and voluntary. It's resource-oriented and aims to empower families. So it's in line with recommendations. The program is being implemented since 2015 and rolled out all over Austria with financial support of the EU during the years 2022 and 2023. Until the end of 2024, about 16,400 families were supported so far. Here we do have a documentation system for our program, and as a National Center for Early Childhood Interventions, we analyze the data annually. And here you can see that we do reach socially and socioeconomically disadvantaged families well. The blue columns are the percentages of single parents, families in risk of poverty, etc., among those families supported by our program in 2023. The red dots are the reference percentages of a similar subgroup within the general population for Austria. On the right side, you can see that we do reach families early. More than 25% of the families supported in 2023 got in contact with the program during pregnancy, and about 70% within the first 6 months after the child is born. At the beginning of the support, the family supporters have a look at a variety of aspects and assess if these are rather burdens or resources. They do this together with the family. The psychosocial health of the main caregiver is in most times the mother, is the missing social network, the financial situation as burden, and the security of housing as resource. Since the beginning, there have been some evaluation and research studies of our program, and they show that it is possible to strengthen resources and reduce the burdens of families. The families themselves report that they really appreciate the talks with and the knowledge and tips of the family supporters. So it's quite helpful for them from their point of view. But we also see that we can really reduce the financial burdens, for example, the anxiety, exhaustion. We can improve social net, child development, and other aspects. So there is a clear benefit for the supported families, improving the social determinants of health, and therefore the basis for a healthy upbringing of the children. This year, we distinguished between income groups in the analysis of our data. So we do have the data on the income of the household for about 10,000 families supported in the years 2015 to 2024. And you can see that the higher the income, the more likely families get in contact with the program themselves. That is the blue area of the bars. Of course, in these cases, often also somebody else informed the family about the program, but they were actively reaching out to it. While in other cases, somebody else did this for the family and with consent of the family. What we know also, you cannot see here, is that the higher the income, the more likely families are referred to the program by the health system, for example, hospitals, pediatricians. The lower the income, the more important are child and youth welfare and diverse counseling services. When you look at the reasons for referral, you can see that the lower the income, the more likely families are referred due to the need for administrative support, medical and social burdens, as well as financial problems. The red bars are the families with an income below 1,000 euros per month. The green bars are families with an income of more than 3,000 euros per month. The colors are the same for this slide. An important aspect is the ability of parents to accept and care for the children. Here you can see that for all income groups, the most problems occur concerning appropriate responses to emotional needs of the children. But for all aspects, you can also see that the lower the income, the more likely families have problems with accepting and caring for the child. This slide shows the improvements we can achieve within the family support in percent of those families where the support was completed until the end of 2024. You can see that in line with the reasons for getting in contact, it is possible to improve the situation. The lower the income, the more likely improvements of the financial and housing situation, of administrative issues and education can be achieved. But unfortunately, also no improvements are more likely. This has several reasons. For example, in some cases, the burdens are that complex and high due to the perceived child welfare risk. At some point of the support, the child and youth welfare takes over. This is just one example. Most important, I think, it is possible to reach and support a population group which otherwise would not get in contact with a supporting system. So overall, we can see that the program works, it achieves its objectives, but it's still rather young itself, and we cannot say anything about long-term effects yet. And although there are limitations due to structures and barriers in the health and social system, we can point out we can only point out them and have not the possibilities to change these structures. We can only talk to policymakers, decision makers, and raise the awareness about that. But that's our task as national center. So if you want to learn more about the program, you can find some information in English on our website, but also in the EU Best Practice portal. And I want to thank you for your attention.
Thank you so much, Marion, for this very interesting input. And we do have now time for questions, but also comments. So if you would like to come in, please unmute yourself and maybe turn on your camera. For me, in order to moderate, it would be easiest if you could raise your virtual hand. If that's too complicated, you can also raise your physical hand. So if you have any questions on the data, either from the report or from the program that Marion presented, or if you have a comment with additional data, maybe that you might have or experience from your work, really every reaction is very welcome. And I see a first hand. It's Professor Arajau Soares. Sorry if I mispronounce your name. Thank you for coming in.
Not a problem. It's a difficult name. I'm Portuguese, so it's not a problem. So I really enjoyed very much this presentation, the whole morning, of course. But I'm very interested in this Frauenhilfe project in Austria, and I'm just curious, because you were saying that people who are from a low SES but still earn more than 3,000 or 3,000 are more likely to be picked up by this program, either themselves being referred by themselves or by friends or by healthcare professionals. My question is how do we go about disseminating? How do you guys go about disseminating the program? Is there training available? And so I just wanted to know a little bit more about this. Thank you. Very, very, very good initiative. Amazing.
Thank you for this question, Marion. Please go ahead. And I also see in the chat that there was a question for your website address from the Frühe Hilfen program that you can maybe answer afterwards.
Okay. Well, we know that we need, or our network manager of the program, they invest a lot of time in raising the awareness about all the professionals and all the organizations who are in contact with the families with a pregnancy or during the first 3 years of a child. We know that it is really important to actively inform families about this possibility and to motivate them. So there's not a training for all those professionals, but we had an additional research project with where we worked with medical staff and diverse professional groups from the health area and asked them what they need. So in that context, we prepared some material which is really handy and allows them to get an impression on what I should look at, what would be an issue, why would a family maybe need support, and then they can inform the family. What we always tell them, they don't need to do a proper assessment. It's sufficient that they inform the family and get them to get in contact with the program themselves, or they do it for them. And then the family supporters, they do the assessment. So even if they have simply a feeling that there is something wrong, it's good to motivate the family and get in contact.
Thank you very much.
The website, I can share the last slide again, maybe.
Yes, that would be good. And then maybe copy the link from the slide in the chat. So it's, yes. And maybe I see you have a follow-up question, Professor Hau?
Yes, I was just wanting to say that, as I've been there, I've been a pregnant woman in hospital settings, and I wonder if there's any scope in making this something that everybody knows about, something that is on the maternity pack. I was a mother in the UK, and something that comes on the maternity pack with information. With some information about this, but of course it's, again, still information is difficult to read. So in all these amazing projects, it's always important to think about how can we facilitate implementation, and particularly implementation for those who need it the most. And so that's why I asked my question. And so, yeah, but that's, you know, you're doing what you can currently, I'm assuming, with the resources that you have, but it's really an interesting project, and I'm very happy that I stayed here today and listened to it. I'll try to learn more about it. Thank you.
Thank you so much for the question. Are there other questions in the room? Then please raise your virtual hand, either for the project or for the data on Austria, or something that struck you very much. Otherwise, I also have something that struck me from the program, which is, I mean, we are now discussing, as my policy colleague Sylvia mentioned, the affordable housing plan that is upcoming at a European Union level. And Marion, you mentioned that in the improvements that you measured, the housing situation was one that especially lower socioeconomic groups managed to improve. Can you tell us a little bit more about this? How exactly was this done and measured also? So when, as of which point has the housing situation improved, and what are the concrete problems in terms of housing that those families encounter?
I think in the most cases it's a combination of a financial and housing situation, because often the families are not the housing is quite expensive in Austria meanwhile. So but often families don't receive all the financial support they could get. So the program helps them to apply for these different kind of financial supports, and that enables them to pay for the rent. And the other thing is, if they also already have debts, that the program supports them to get in contact with clearing services, or services working with them, how to deal with this and how to use their money in a better way, so they can have enough money for the rent, for example, and for the food, whatever they need. I think that's the most relevant ways to support.
And this financial counseling then comes from partner organizations that do specifically those offer specifically those services, or?
It depends a little bit. The structures in Austria, in the regions, are quite different. So in some cases, there is a very good service, specific survey you refer to. But in some cases where you don't have such a service, the family supporters, they come from a broad variety of professional backgrounds, and they can help themselves also. The idea is to use the regional network, but if it's not possible, because if it's not existing, then they do as much as they can themselves.
Thank you. Are there other questions from the group to Marion or myself? It should also be mentioned that so now we cover all countries in this big technical report, and we have the summary report. You can find all the information on Austria that I shared. The graphics are in the technical report, so the long version. We will try at some point to maybe have some country fiche, let's say, but this is for later. Yes, I see a hand here from Mr. Pfeiffer.
Hi, everyone. Thanks for this wonderful presentation. This is not really a question, just a comment. So I work as a research fellow in London, and we look at unpaid care as a social determinant of health. So which means adult social care, but also childcare. So I really liked the presentation from Marion that she considered childcare as well and care elements in her presentation. And I really hope that we see more work also at European level on unpaid care. So thank you very much.
Thank you very much for your point. If you go to the technical report, you will find a heat map which covers different factors that improved or did not improve in terms of housing in different countries, but also the weight of unpaid care. And I would have to check again how the situation in Austria is exactly, but there are indeed differences, and in general, unpaid care problems have increased in many European countries, but don't want to say anything wrong. I would have to check again the details for Austria. Sylvia, you have a comment.
Yes, if I can just add a comment on the unpaid care. I mean, thank you very much for picking up on this issue. As Anne said, the report covers for this, and at the European level, there's, let's say, a high level of awareness about how much unpaid time goes into care, which impact women disproportionately, both in terms of looking after the children and then the elderly parents. So it's like a never-ending story. The impact that it has in terms of economics, because women then might not be able to work or they need to get part-time job, but also the issue of lack of social services. And the fact that it's increasing is a result of the fact that the public sector is just cutting on social services. And at European level, there's a care strategy. It's part of the European Pillar of Social Rights, and the issue of unpaid care is also mentioned as one of the fundamental issues we should consider, find solution, address, and just learning from each other.
Thank you, Sylvia. Very important. In order that we don't miss to go back to the plenary, because it's again the first link, I will share it already in the chat so that I don't forget. And we reconvene in the plenary with everyone to have a quick wrap up from all the sessions so that you can also hear what the other sessions say. So here is the link. And I saw that there were 2 more questions. I think we have time to cover them before we have to go back to the plenary. One was concrete measures on mental health. Marion, that was a question to you in the chat.
Well, the family supporters, they motivate families to attend, for example, psychosocial activities, but psychosocial support. There's always also a reluctance among the family. So it's very helpful if there's somebody you already trust and who motivates you to get in contact with some psychotherapist and also enables you to do so. And in some regions, there are specific psychosocial offers for those families supported by the Friedenhilfen, like they can receive 5 sessions of psychotherapy, or there's a specific group with 8 sessions for them. And we made an evaluation of that additional offer, and it's very helpful for the families.
Mm-hmm. Thank you. And then there was a question to me, I believe, in terms of the reasons for the differences in self-reported health, but also self-reported mental health, and whether this could include the different circumstances, political circumstances, economic circumstances. Well, this is difficult to say because we only have the data from the European Social Service on the health and mental health, but we have the data on some of the causes in terms of housing and financial strain, etc. It's difficult to say something about the wider economic and political circumstances in each country. However, the feeling of income was, for example, the most important factor affecting health and mental health in all countries. So this is also, I think, clearly something showing that economic circumstances are a major determinant for people's health and mental health. And this is clearly one of the most important findings also of our report, that the feeling of income is a factor that should not be underrated. So in order to allow everyone to switch rooms again, I will slowly close our breakout session on Austria here. Thank you so much for your time and attention, and we meet again in the plenary. See you there.
Welcome, everyone. I think we are ready to start. We have already 25 participants, and I hope others will be able to join us in the coming minutes. Thank you very much for joining the breakout session on Norway. We'll take the opportunity here to go a little bit more in depth on Norway's country profile and to examine more closely the shifts, the magnitude of the shifts, or who shifts in health change have taken place over the last decade. And then we'll have director from the Directorate of Health as well, presenting along with me what are the results from their studies showing vis-a-vis Norwegians' health. Without further ado, I'm going to share my slides so we can start the presentation. I'm sorry, this past 2 days, like all technical issues that could happen to me have happened. So now it's showing. Can you see the presentation mode or also with the slides?
Yeah, we see it now.
Presentation mode.
Oh, so it's without the notes because it's giving me the notes as well. Anyway, so here's the focus particularly on Norway. And what we see from Norway is that actually the rate of poor health, you have highlighted it here, has increased significantly over the past decade, from 23% probability of reporting poor health for Norwegians in 2014. It is up to 27% in 2024. So what has happened to the social groups within the countries? Again, we looked at education, and now I have more time also to explain the graphs. So the blue circle is the level of poor health for each educational group. On the right is the graph for high, on the left is the group for high educated, and the left is for low educated. And so from 2004, in 2014, the blue circle, the shift is where the red circle is landing, and the magnitude is basically the difference between those two circles. As you can see from the high education group, which is basically tertiary educated, that's how the high education group is defined in our study. It went from roughly 14% to 19% reporting poor health. So it's an increase by almost 5% reporting of poor health. Whereas for the lower educated, which is people with lower secondary or less education, this went from 31% in 2014 to over 46% in 2024. So as you can see, there is quite substantial shifts in health and deterioration in health, particularly among lower educated. But as you can see, also higher educated have not been immune to this shift. How does this translate in relative risk of inequality? It's that we see, again, an increase in relative risk. You have Norway highlighted. It was more than twice, like 2.2%, 2.2 more likely to report poor health, the lower educated compared to the higher educated, and now we are close to 2.5. But this is just the magnitude of inequalities. But what does explain inequalities in self-reported health among Norwegians? Here we have an analysis of main determinants of health. We run a regression model, and we're able to include only each of them separately. So this is the caveat of our study because of limitation to power in the data, not necessarily in Norway, but to be able to have the same analysis for all countries, we had to take some decisions on limiting the scope of the analysis of looking at multiple determinant contribution simultaneously to disentangle both their direct and indirect, like interactive effect between determinants. But thinking of overall effects, we see that the largest differences are explained in Norway from body mass index, followed by a sense of control over life. And third is smoking, and the last one is actually ergonomic hazards. So again, these are overall effects, which means that if we had been able to control for instance, BMI together with another risk factor, like from the occupational or the financial, we might have seen a different contribution in explaining inequalities of BMI, because BMI might be capturing also effects of other determinants that actually were not included simultaneously in running these equations. But this does not preclude the fact that actually all these factors that are listed here, these 4 factors, would materialize even if we had a more intricate modeling. Going to the rate of self-reported poor mental health, there are no significant increases in Norway. Actually, it's 0.7% the increase in poor mental health overall in the country. And so this shift is not statistically significant, and we can say that there is some stability there. However, we show here data of shifts within occupation groups. On the left side is the high occupation group, and on the right side, the low occupation group. And you again can see the direction of change. So, for instance, like in a country where there are no shifts overall in the burden of poor mental health, these groups have actually taken different directions. So for the high occupation group, they started at 3.5% probability of reporting poor health in 2014, and they are over 5%, 5.7% now in 2024. So this is an increase by something over 2%, but nevertheless, it's still an increase and showing a pattern of increasing burden of poor mental health among higher educated. For the lower educated, we see actually a decrease in poor mental health, where they started from reporting in 2014 almost 14% of low occupation, which is actually working class and otherwise, like manual jobs. It's from nearly 14% probability of reporting poor mental health, and that went down to 9% in 2024. So we can see here that this burden of poor mental health has been unequally distributed and favoring mental health levels for the low occupation in Norway. This is also visible on overall relative inequalities. So you can see that in 2014, they're like more than four times more likely to report poor mental health, the low occupation group in 2014 for mental health, and that went down to almost twice more likely to report poor mental health. So inequalities persist. And this level of inequalities is not entirely coming from improvements only in the low occupation, as you just saw, but also deterioration or signs of deterioration of mental health among high occupation groups or white collar. It is very important to highlight this point because we need to be very critical. Our call is for our community to be very critical when we look at trends of health inequalities, because under shifts of decreasing health, decreasing inequalities, especially in relative inequalities, it might cover very different, like in the case of Norway, opposite direction of health for the social group
studied. And if the baseline for us to start then investigating what policies might have resulted in this shift in the magnitude of inequalities, even in the reduction, we might, if we are not critical of the effect measure itself and where that effect measure is coming from, if it's coming from improvements or actually health loss, that we are achieving lower inequalities, then we might run the risk of starting from a faulty baseline to actually find which policy recommendation should be pushed forward. And explanation of occupational inequalities in mental health. So as you can see, luckily, only 8% of the population that reports poor mental health. So the statistical analysis is really limited what you can do, because the sample sizes are quite small when it comes to poor mental health by each occupational groups. Again, here for Norway, we run each regression analysis separately, so included each of the determinants separately in the model. And the largest explanation, most important explanation, who was able to explain the largest level of inequalities was feeling of income. So how confident people are that they can meet their need within their current income, followed by smoking. Then employment status was also an important factor, and lastly, job control. So these are the data we have from Norway. The key takeaways are that overall levels of poor health, unfortunately, are increasing. And this is definitely something to keep our eyes on, because, as I mentioned, self-reported health, it's a measure that has a very predictive power of premature mortality, like even more than any objective health measure, at least ever studied, because self-reported health is a very simple item. We feel like, how has your health been? But it is able to capture not only the physical health of respondents, but as well how they, like the context where they experience their health, like how enabling or disabling is the context around them, the exposure to the risk factors to accommodate their body and how and their chronic conditions. Educational inequalities in poor health are increasing, at least among educational groups that we studied for self-reported health. Whereas what we see for poor mental health is that overall it is stable, but there are worrying signs that the high occupation group is showing an increased trend of poor mental health. And with that, I thank you for the attention, and I can conclude the presentation for Norway. And I give the floor to Øyvind Jave, who is the director of the department in social determinants of health in the Norwegian Directorate of Health, to see how our analysis actually speaks to what they have been examining, probably even more in depth from their country. Thank you, Øyvind. The floor is yours.
Thank you very much, Mirza, and thank you very much to you and your team for this very rich and interesting report, which we will probably need some time to digest. There are a lot of details in it, and we'll definitely use some time and energy to disaggregate all the data. Can you see my presentation now? Okay, so my name is Øyvind Jave. I'm a director in a department called Department for Social Determinants of Health. I'm very happy with that, with the name of my department. I should say also that I used to work strategically with the social inequalities in health for several years here in the Directorate of Health. I now have other responsibilities as well, but my heart is very much still with reducing social inequalities in health. I'm sorry to say really that this report confirms what we have known for some time, namely that social inequalities in health are substantial, even in the otherwise relatively egalitarian Norway. And when I say relative, that is compared to many other countries in the world, looking also beyond Europe. We have two other recent reports that have highlighted not only that there are substantial inequalities in health and well-being in Norway, but also that these are inequalities that are possible to reduce. And the reports I'd like to mention here is the Norwegian Marmot review we had a couple of years ago from the Marmot team in London. And also we had a recent report on inequalities in avoidable deaths in Norway, which of course shows that we have substantial inequalities that are, in principle at least, possible to reduce. We know that self-reported health, which this report very much focuses on and which Mirza highlighted, is a very good predictor of many others and more objective health outcomes, as Mirza pointed out. Therefore, we fear and expect that increasing inequalities in self-reported health today may manifest themselves in widening gaps in morbidity and mortality tomorrow. We already have a high average life expectancy and good general health in Norway. So I think it's very much time. The time is overdue, really, to now focus on the leveling up of more groups in society up to the same high standards as those best off. At the same time, we also need to be a bit cautious because this is, of course, not done overnight. And I think one of the things that the chain and EuroHealthNet report also points to is the importance of material resources in this picture. So even though we can work with social inequalities in health within the health sector, we clearly need to change some other societal determinants too if we want to succeed. This picture we've seen before a couple of times today. It's from the report, and it shows levels, not inequalities, but levels of poor self-reported health in a bunch of European countries in 2014 and 2024. I think Mirza explained it maybe a couple of times already today. So we see that Norway, in absolute terms, is not doing too bad, despite the fact that more Norwegians consider their health fair or bad or very bad in 2024 than in 2014. And we can probably discuss to what degree self-reported health is comparable across different countries and contexts. If we have time in the discussions, I'd like to hear your views on that, Mirza. For instance, there was a couple of years ago, we noticed a very sudden sharpened drop in self-reported health in Statistics Norway's health surveys, and nobody quite understood what had happened until someone pointed out that they had made some changes in the succession of questions in the survey. So the year with the drop in self-reported health, the questions about health was asked immediately after questions about personal economy. So It's probably some. It's a health measure that's it's culturally, and it's dependent in some way on the circumstances and yeah. So but I think also that's probably one of the things that makes self-rated health also a very good measure, because it catches more than just the physical and objective factors. Anyway, my point with showing this is not the comparison between countries and contexts, but rather to compare this graph with this one, which looks a bit like the previous one. But this graph shows geographical inequalities in self-reported health, the same health measure, between neighborhoods in Oslo, the capital of Norway. And my point being that if we zoom in, the within Oslo inequalities in self-reported health are almost as large as the between country averages in Europe. And for those of you who do not know the geography of Oslo very well, I can tell you that this is a very classic east-west gradient. The best health is found in the affluent western parts of town, but it decreases gradually the further east you travel. And for some reason, health inequalities in Oslo have always been quite large. So Oslo is perhaps and hopefully not too typical in a European context. But the point remains that even high absolute health levels may conceal quite big inequalities, and our public health targets should probably not focus on pushing average levels incrementally further, which I think they very often do, but rather on a more equal distribution. So to finish off on a somewhat more positive note, I'd like to conclude my comment with pointing out some of the possibilities we have right now in Norway. First of all, as pointed out already, we have quite good data and also some expert advice that follows with them. Although I noticed that Terje pointed out that we need even better data, but we have some at least. And I've already mentioned the Norwegian Marmot review, and we have the report that we discuss here today. We also had a major revision of the Norwegian Public Health Act, which was actually quite good. It's an act from 2012, but it got even better through a major revision that passed Parliament this summer. And among other things, the revised act places a clearer responsibility on the national level, both for doing systematic public health work on the national level, but also on the national level to support the municipalities better in their public health work. This summer, we also the present Norwegian government also presented a national well-being strategy, which is now in the implementation process. And I think this is relevant to mention here because self-reported health is probably an indicator of well-being as much as of physical health, as mentioned. And the well-being strategy provides a good opportunity to work towards a more equal distribution of both physical and mental health and well-being. And then last but not least, we just last week had a public commission presenting a report on priorities in public health work and how to prioritize between different measures in public health work. It's actually the first report and recommendation of its kind in Norway. And the Commission recommended 4 priority principles: benefit, cost, autonomy, and last but not least, distribution. So we also have some new tools there to work with and prioritize measures that actually levels out social inequalities. So I think I'll end my comment on that somewhat positive note. Thank you.
Thank you very much, Eivind, for going a little bit more in detail, and also at the country level and using the Oslo example. It's very telling that inequalities really get to the fiber of every city, and it's not only at the national level, but you can actually experience in everyday life and see it also geographically, being it visible of how the living conditions of people change and seeing how that affects health. Before opening the floor for questions, I wanted just to address a little bit the discussion of self-reported health, because there is a large discussion, not only among ourselves, but with economists and healthcare services as well. Like, why is it useful? Is it reliable? What is it telling us? Like, can we compare it? Like, can we learn from a country because they are using the same measure and they are enacting different policies, and would that be useful for us? So self-reported health, as I mentioned, particularly within the country with these changes, it is definitely reliable, unless you, as you mentioned the example, you suddenly change and you prime people to think of their health right after they have thought of something that might not be going so well in their life. So in the case of the European Social Survey, self-reported health is, together with a measure on limiting long-standing illnesses, are present in the core survey, and they have been in the same place since 2002. So these variations that might come from priming are definitely not an issue insofar as the data we are reporting here. And so it is definitely safer, and there is less confounding, so to say, noise when you compare within the country across time, given that you have not primed people by shifting the order of the question. But even between countries, I think my answer to you and my arguments actually placed in a whole PhD 10 years ago are that it is reliable, because exactly my argument was that there is this misconception that self-reported health should be objective health, but it is only in part objective health, because we have at the same time people who objectively are living with several chronic conditions and they report good health. And then you have people who objectively, within the same country, they have no chronic conditions to report of, and they report poor health nonetheless. And how do you reconcile these experiences with their reporting? And for a short answer, because I really want to hear also the opinion of our participants, is that you reconcile it through context. How is a person with multiple conditions, how is life adapting to this condition? Is he feeling more job strain? Is he feeling more job insecure? Is he losing contact with peers and friends and family because of it? Is he losing income? And if all of these things are not happening, the person adapts to the disease and still is able to report that he is living life in a sense, it is in good health. But if the person, even without any physical condition, is under all of these strains, definitely is not feeling well. So that's how his body reflects the social conditions of his living, although it has not physically yet materialized in a condition itself. So in that perspective, that has allowed me to compare between countries safely, because I'm comparing between the context of living of the people. And if this context is telling us something, is that it's making people feeling sick early on and feeling sicker even when they don't have a condition vis-a-vis another country. And are those contexts that we should examine to be able learn from each other and all the initiatives, and from the initiative like the one you mentioned. But I really, who has a question can raise their hand or can just open the mic if there are not too many and we can handle it. So we're very happy to use this last 5 minutes to hear your thoughts on the data and on the initiatives presented also by Evin, or to share your experience about your expectations maybe in your own country, and your thinking about policy responses may be necessary and cross-learning between different contexts. Okay. Hi, Dina. Yes, the floor is yours.
Hi, Mirza. Hi, Evin. Nice to see you, and thank you for all the fantastic work that you have been doing with this report, Mirza, and Jane and EuroHealthNet. I was just curious also, and also to hear from other countries, because in Norwegian context and also in the Marmot report for Norway, we recommended that the health equity system for Norway should move in a direction of a well-being economy, placing well-being for all first, and also looking at all key system levers within the system that can, as Chris mentioned, to renew the social contract and move us towards the goal of well-being for all. So, and currently in Norway, we are doing some work on this, but I think it would be really interesting also to learn from other countries and how they approach this work and how they move things forward, and especially from Slovenia, who's you pointed to in the report as well, that has actually made some progress in the last couple of years and done exciting things, especially when it comes to social participation in health. Yeah, thanks.
Thanks, Dina. I hope we have someone from Slovenia in the call, or someone else who wants to share their country experience. Yes, Polonka.
Yes, hi. I'm not very familiar with the development of the report. I was following the yesterday and today webinar, and I will go through it thoroughly. I just wanted to say that perhaps we made this big progress because a couple of years ago we had this great opportunity to be able to use Norwegian funding for our development of health promotion centers in Slovenia. So I was this year thinking many times that we should get in contact with our Norwegian partners from that time to brief them on the progress that we have made. And that was really wonderful. And I think we really made good use of that funding. So I thank them again this opportunity, and I will read the report thoroughly. And I work with children, so I hope we will have more data on children in the coming years regarding social inequalities and progress.
Thank you. And Dina, just to explain a little bit more on the data and why do we see some progress in some of the countries, and particularly we see in Poland, in Slovenia, and in Hungary. When we disaggregated the data of the scoreboard about employment, we realized that in all of these countries, there was a larger participation of women from lower education in the labor market. So that was the largest shift among all educational gender groups. So we know in self-reported health, women tend to report worse health, and especially the lower the level of education, the higher the probability of reporting worse levels of health. So I think in these countries, besides definitely prevention, promotion, knowledge sharing, there has been a lifting of a specific group, which is basically carrying most of the burden, or a large part of the burden of poor health in the countries, being included in the labor market, hopefully with decent working conditions, or at least they have already met that minimum of being more independent and active in the labor market. But we see like 20% more, between 20 to 35% more women with lower education have actually are active in the labor market compared to 10 years ago across these countries. And those are most likely the ones who have benefited also in terms of health. And we do see the opposite trend in countries like Austria, for instance, where all the improvement in the labor market participation has accrued to men with higher education. Like women with higher education have lost a bit of their participation, men with low education, and particularly women with low education are out of the labor market with around 15% compared to 10 years ago. And we see that overall health has improved and inequalities have increased at the same time. And then by disaggregating further, we see whose life has changed, at least in terms of employment. But we should be able to do this and cross-reference, crosswalk different dimensions of different types of risk factors. But it seems like all improvements in health in Austria are actually improvements among the high educated men. And health losses are mainly from low educated women. So these are the trajectories of life, like pulling further apart and materializing as well in social inequalities in self-reported health. But definitely we need to go more in depth on this data and invite every one of you who is more interested to look at the country to open lines of communication, collaboration, so that we use this opportunity to use together this recent and very comprehensive data so that we can build strong country profiles and going more in depth on what are actually the drivers behind this health shift. Thank you so much for joining. I hope this was also useful for you as much as it was for me to learn particularly more about what is happening in Norway. I'm looking forward to coming to Norway to discuss this further. And I invite every one of you to join the other link we have for the plenary session. You have it also here in the chat. Thank you so much.
Thank you, and see you there.
So yeah, these breakout sessions provide us with an opportunity to do a deeper dive, as Caroline said, into a specific country, and also to discuss a little bit more everything we've heard. And this workshop will be focusing, as maybe we should say, another case study in depth with the data, the evidence, and the approaches from Spain, which we've already heard a little bit from Anne. Well, a little bit, a lot, a very rich presentation in a short time, but we have the chance in this workshop to go in even more further depth into the situation in Spain, which, as we've heard, also is a very interesting country when it comes to health inequalities and what's being done. It's taken seriously. I remember, Anna Jill, I think in 2010 there was a big conference following the launch of the WHO report, the Social Determinants of Health report, 2 years later, but to really put the issue of health inequalities also on the European agenda. At that time, there was a lot of momentum, and Spain was taking the lead and continues to be, I think, within Europe, a leading country that has this, as we heard, driving equity across sectors, and the Ministry of Health is really has been also at the forefront of this, despite what we know, quite limited capacities. It's amazing what you do. But Spain is also a really interesting country, as I'll present now the data, because it's a very mixed picture, what's happening there, with positives, but also some negatives. So I will start by showcasing, pulling out the data from Spain from the report, and then Anna Luciano will present in further depth some of the examples of what they're the equity tools and the things that we're using, and then we'll have some time to discuss on the basis of the Spanish example, or maybe drawing from other countries and other examples, what can effectively be done. So I will share my presentation. That. Okay, let's do this. I think you can you see my slides?
Yes, we can. Thank you, Ingrid.
So with respect to health, self-reported, what's terms of what's been happening in terms of poor self-reported health in Spain amongst 25 to 75-year-olds. We see that Spain is, we could say, a mid-range performance. It's actually amongst those countries that are reporting 30%, where 30% or more of the population is reporting poor health. And it's interesting to see because Spain is also the country with the highest levels of life expectancy in Europe. So there's quite a discrepancy between life expectancy and self-reported poor health. But when we look at, and this isn't on the slide, but it's in the report, just Spain as an example of healthy life expectancy, it's in this respect also a mid-range performance, because I think healthy life expectancy is around 74 years. So people are living long, but less long in good health, which can also maybe explain the fact that there is still, relatively speaking, levels of self-reported health are quite high in Spain. And in the last 10 years, they've increased slightly, so by 2%, which is significant still, given the population of Spain, this increase. And as Caroline was mentioning, a lot of the data presented in the report doesn't take into account the mid-education levels, but if you look at these line graphs of what's happening across the population, that we do present more towards the end, before we're looking at first at the high and the low group, but then the mid-education group, we see that a lot of that loss is coming in Spain from the middle socioeconomic group, those with more vocational, upper secondary vocational level education. While we see across the board, there's a decrease in health, or an increase of poor health. So that's the red line shifting up. The red line is 2024. The blue line is what happened in 2014. So the fact that it's shifted up shows that there's this increase. And across the board, but particularly in the mid-education groups. Spain is, however, a good performer, and one of the best performers when it comes to levels of educational inequalities in poor self-reported health. So we see that in the average, the relative risk of inequality is around 1.45, which means that less than half, well, the lower socioeconomic groups have maybe less than half a percentage, half. I don't know how to say that with, in terms of other groups, it's twice on average, 2 times as much chance to report poor health. In Spain, this is much lower, less than half the chance of reporting poor health. So in that respect, this is quite positive for Spain. And then when we look at the drivers, what's driving inequalities in poor health in Spain, it's the main factors that emerged were social networks. Body mass index plays a big role, the feeling of income, as well as material hazards, so working conditions at work linked to employment conditions, long hours, and this kind of thing, rather than just the physical risks or like exposure to chemicals and this kind of thing plays a big role. Then turning to self-reported poor mental health. Here, the story is more positive of what's happened in the last 10 years in Spain. Mental health, levels of mental health have decreased. In 2014, they were about 17% of the population was reporting poor health. And now in 2024, in the last survey results, about 14% of the population is reporting poor health. So that's, again, positive. And here again, we see, as a result, the the graph line has shifted down to reflect this, but it shifted down for the low occupation and the mid occupation groups. And we see slight increases in poor health amongst the high education groups. So in this respect, we don't see a leveling down across the board of good health. So from our perspective, this isn't a full success story when it comes to reducing health inequalities, because something is happening with those high occupation groups. So, in terms of the changes in relative risk of occupational inequalities in poor self-reported health, we also see that these have decreased considerably, and that Spain here too is amongst the better performers across Europe. And the explanation of occupational inequalities and mental health are feeling of income, material hazards are the ones that came up, social network, and job control. So a lot of so occupational determinants as well as material determinants. And it's interesting that social network comes up in Spain compared to the other countries. Okay, so that provides a context for Spain, maybe to kick off our discussions. And maybe I can just ask if there are any questions around this before we hear more from Anna Gilles about what specific policies and measures, and a bit more around what you're doing to address the situation. Are there any questions? And if not, as I see, I'm from EASP.
Yeah. Good morning. Bueno, firstly, congratulate a lot for the report and also for the Anna's presentation before. And we had a question that is related to non-communitarian people. Is there any disaggregated data about non-communitarian people, non-European people in the report?
In the social survey, I think Mirza would be better placed, so maybe we can take that question in the plenary, because I am not sure how specifically that's specified within the survey report. I think it's more general populations, and it comes so exactly how who is surveyed and what percentage that would be. I assume it's not a distinct population, and we certainly didn't disaggregate in our analysis. That goes much further than we were able to do. But we can take that question for Mirza to the plenary.
Okay, thank you.
Any further questions? Yes, I see Carlos Diaz, hand up.
Yes, thank you very much for the very interesting webinar. And thank you also for the very interesting presentation regarding Spain. I chose to be in this room because as a neighboring country, we share some cultural similarities. But one of the similarities is the variety that we have in the Iberian Peninsula between the north and the south. So my question is if there is any inputs that can be given by the Spanish colleagues on regional differences, and then on the autonomic responses that are being given. Thank you.
I think, Anna, maybe if you can, did you understand the question? There's noise in the background. Maybe I can ask Chantal, can someone bring me some headphones?
I think I understood the questions. The question you were talking about regional inequities and between north, south. I don't know in the data that has been included in the report, but in Spain we also have the National Health Survey that it's conducted periodically, and there you can study data disaggregated by region. It has sufficient statistical power to compare regions. So also one of the studies that I'm going to present now as additional data on children has also this comparative approach between regions.
Thank you.
Thank you. Sorry, we have building next to us and they've started drilling suddenly, so it's affecting my ability to hear. Maybe Pilar is the last question, if it's short, and then we can jump into the presentation just to make sure that Ana Gil has has the time to also present.
Okay. Thank you very much for this meeting. Very interesting. My question is related with the poor self-perceived mental health, because for me it's very surprised the reduction in 10 years. I don't understand the reason. I don't know if you have any explanation for this reduction, because it's not coherent with the other studies in Spain, because mental health is worse actually nowadays. I don't understand this result. I don't know if you have any explanation about this.
I think it's interesting to hear. And the only explanation could be that our population that we looked at 25 to 75-year-olds, so really the working population groups, in partly because the report was focused on EU, also the level, and we also looked at EU policies, and they tend to be focused on employment, social affairs, their policies on this, what can be done around this population group. Also because WHO, the Hesley report, will be focusing on young people and older people. So we thought, just to complement that, that's the reason we chose that. And then while we know that mental health problems at the moment are very much increasing amongst younger populations and are generally higher amongst older populations. So that could be an explanation for these different outcomes for Spain. But I think in further iterations, we see this report very much as a baseline for us that we'll be working on and trying to understand, and maybe we can dig deeper also in future years into really what's, what variations are, what different data pools and putting these findings together with national data to dig in. Yeah.
And maybe we have to study more deep this question. Yes.
Yeah.
Thank you.
Thank you. So maybe, Ana Gil, I can turn to you to give us more information about what the different programs and measures that you're taking. We heard a little bit about that, but again, this is really an opportunity for a deeper dive into particularly the checklist for equity health equity strategies that you mentioned briefly in your previous presentation.
Yes, perfect. Thank you, Ingrid. Are you seeing well the presentation? Yeah. Okay. I was asked to give some additional national data on what was presented on the report, and also on focusing on the example of the checklist for equity in health strategies, programs, and activities that that it's included in the report, and just to go a bit more in depth. So as additional data, we already talked about the National Health Survey, which is a general survey linked with the European Health Survey, and we already know a bit more about that. So I wanted to focus on two studies that may be less known and are a bit more targeted. One is the health behavior in school-age children, the HBEST, which is an international study, mostly formed by European countries, but also from outside of Europe, and it focuses on children. It is conducted every 4 years. Our last edition is 2022, and it ranges from ages from 11 to 18, and it has a clear equity analysis by different axes. We have sex, age, region, as I already said, also type of school, and an aggregated indicator, which is family affluence scale, which is more similar to the family context, the socioeconomic context of the children surveyed. And we also have a specific report on health equities, on health inequities, which in the case of this last edition, we still haven't published it yet, but you have available the rest of the editions. No, this one is new, sorry, from this year. So we will be publishing it soon, but we already have on the website all the data disaggregated by these indicators. And for example, in this study, emotional well-being appears as one of the aspects that has decreased from previous editions, talking about mental health. And this is an example of what we already have published, waiting for the specific report on health inequities. For example, on self-reported health status, we find inequalities on sex, on age, and also on family affluence scale. So this data, we already have them published. And one thing that we have really seen is that many indicators have worse results in female teenagers. So it's one of the aspects that should be taken into account when tailoring policies. And the second data that I wanted to highlight was the health survey Roma population that we have conducted already 2 editions that are already published, 06 and 14, and we are right now finishing the data analysis and the review of the 3rd edition, which was conducted in 2023. The survey has a particularity that it's done with the same methodology as the National Health Survey, so it helps us compare it with the results of general population, and it has highlighted already what we knew, that there were great health inequities on Roma population, that in many indicators Roma population have worse results than the most disadvantaged social group. So it's really an important aspect to take into account, and it justifies all the policies that are in place to improve all the social determinants of health of this population, and obviously specifically the discrimination that they suffer. And focusing on how we are one of the tools that we are using to integrate equity into health strategies, program, and activities. I wanted to highlight this checklist that was published in 2022, but it comes from a previous work since 2010, where we started a capacity building and a methodological guide to integrate equity. We did it at national level and with regions, and also afterwards we supported WHO with also capacity building to other countries, and collaboration with them with their methodological guides. And in 2019, we thought that we needed an updated checklist, which is a part of the methodological guide that we have. We needed like a specific tool that was really brief and comprehensive to really in a fastest way review the equity that how we are addressing equity in a strategy or a program, and find already there some improvement proposals to put in place. And we are also complementing it with capacity building to help to encourage people to use this checklist. So this new checklist is mainly aimed at professionals and decision makers working on health activities, program and strategies. We are not aiming at this moment with this checklist to other sectors. They can use it if they want. Some questions should be obviously adapted, but our focus was let's start with the health sector. And it reviews the equity and the social determinants of health approach. It makes you reflect on the results that you obtain, on the questions that you have to answer, and then identify how to improve those aspects that you have identified in the questions. The tool can be used. It's better if you use it with a strategy that's already implemented or you're in an evaluation phase. But it can also be used if you're planning your strategy, program, or activity, because it's you just have to adapt some questions and not maybe have the results, but the expected results, etc. But it could be useful in any phase of the development of a strategy or a program. With this aim of intersectoral work and social participation, the ideal way to use it is to create a group where you can involve citizens related to that strategy, and also other sectors that may be working. And if you want to go in a more in-depth analysis, we have the methodological guide published in 2012, which includes a first version of this checklist and goes on a larger review process. It's in a PDF format, so it's easy to that is easy to fill in, and you can do it online in this PDF, and we have it published in Spanish and English, so it's also for you available in those both languages if you want to explore it. And as we want the checklist to be a tool in itself, that you don't have to be picking up things and concepts and everything from other places, we have done a key concept section to help work through the tool. So in the sense, the tool really focuses on these 4 aspects. We have to see how the interventions work on the social determinants of health, and how the intersectoral work is being conducted, how we are adapting our strategies to people's needs, and how it's this community engagement being developed in our strategy. We have 11 sections that you have in the slide, and which are in total 35 questions, and they address these aspects, and with an important part at the end, reflecting on the social determinants of health linked with the strategy and how we are responding to them in our strategy or program, and these equity challenges that make you review every question that you have answered in the checklist and find solutions or things to strengthen in your strategy or your program to improve equity. And nothing more, available for any questions, and you have I can put the link of all this in the chat, and you can have it also in the presentation. Thank you.
Thanks so much, Anna. It's really interesting to hear more about what you're doing, the different surveys. So HBSC, I think we heard that there's very little information out there for children, although it's such an important population group given the life course and what happens there in later life. But then, there is this survey at least. So I think it's interesting to also talk about, maybe what the strengths and limitations, why was discussed. It would be good to build on this at European level, but also to hear more. Well, and your work on the Roma population, I think, is interesting and important because it's very much a very specific target group. So one that we really have to understand. That it stresses the importance of also working with a targeted approach, because certain communities you really need to understand the cultures and the different approaches to work to really help improve health in those communities. And then also with the guide, to hear more about the guide. And I think you forget, the first things first. I think the health sector, health systems need to get their work in order and to make sure they're integrating health equity. And as you've laid out, it's much more easily said than done. So thank you for that. And I don't know if there are any questions from others. I know I have some questions that arose as you were talking. So to take the opportunity to ask you directly. And if not, maybe I'll dive in. I was just wondering, with the health equity guide, what if there are practical, or if you could say something about the practical experiences of applying it in terms of what changes may have been identified as being needed, or what were findings through the reports. How did applying it change maybe a program or an intervention to make it more effective?
Well, we've had different experiences. We have applied it on our own strategies, and we have been surprised sometimes that even though we know everything on equity, when you are struggling to put in place a strategy or a program, you may not be so aware of all these aspects. So I think that everyone, even the more motivated ones, have to use some kind of tool, whatever it is, to systematize this analysis. People find really difficult to find data, and sometimes data is there, but we don't have it linked to our own strategy. So I mean, there is data, but not always as disaggregated as we want, or as at the level that we need. So that could be one of the aspects, and also well, people really find it also useful because it not only helps you analyze equity, it's like it's also a process of checking the quality of your strategy, not only equity. So it kind of interrelates with the process of any health strategy. And well, I think that probably mainly those aspects, and that you really, I mean, if you really people start using the checklist as a way to criticize on a strategy or a program, and we always try to highlight that it's not that you cannot use this checklist to criticize. Everything can be done better. You have to use it as a way to be more constructive, to find what we can do better. But well, we do things as we do it. We do them with the context that we have, and it's really a way to find improvements that can be made, but with this positive approach, and also that maybe not everything can be done at the same moment, but if you really go through the process, you may find different windows of opportunity to address the different challenges that you have.
Okay.
I hope I have answered.
Absolutely. I see some hands, some familiar faces, so that's great. Sara, you have your hand up. Sara,
thank you very much, Ingrid. Thank you very much, Anna, for this great presentation. And I just want to ask you if, I mean, this is a strategy, or the checklist is a strategy to apply at national level, okay? But I'm just wondering if you have any kind of thinking or strategy or whatever, just to go into the regional level to apply that? Thank you.
Thank you, Sarah. The checklist can be used by any level. I mean, it can be used by local level if they have a strategy or a program, or even an activity. You don't have to have like this macro big context. It can be used at national, at regional, or at local level. It's just we have been doing capacity building also with regions. So it's just a way to rethink your health strategy. It doesn't matter if you're working it at city council or at a region. It's not a problem in that sense. You can use it in either way. I have answered the question. Yeah.
Thank you. Are there any other comments or questions or thoughts, reflections? No. Then I'll jump in, because I think from the findings that I presented, or that the report, resulting from the analysis of the ESS data, as I mentioned, it was particularly the middle classes that seemed to experience higher levels of poor health, so experience a decline in health. And I know it's purely reflective, but it would be interesting. Would you have any ideas as to what kind of conditions? And again, from our analysis, it was it looks like, it's the main drivers that we found for these inequalities were social network, body mass index, but that's, of course, can be linked to a wide range of factors, feeling of income, material hazards. So but we haven't been able to go beyond those kind of headlines and to dig into what's happening within that group based on the ESS survey data. So I don't know if you or others would have any reflection, thoughts around that.
Excuse me, Ingrid, the plenary has already started again.
Oh gosh.
So it's been very quick. But you will find the link to the main session, and then I think we'll have to continue the discussion there.
Thank you for that. I thought it was 12:10, so I was keeping an eye on the clock for. Okay.
12:05.
So we'll see you back in the plenary. Thank you, everyone.
See you there.
Thank you.
So yes, I would just like to welcome you to this session, in which you have chosen Poland as your in-depth case study on how to address social inequalities in health during this breakout session, which will last until, we start 5 minutes late, so I would assume we end 12:05, unless, Chris, you know something I don't know?
No, I think obviously if we can shorten it, that's great, but don't feel too pressured.
Exactly. So, so during this presentation, we will start off with a presentation by myself. I'm leading Chain, and I have some data that Mirza has prepared for me. So during 7 minutes, I will present some specific data from Poland, which would follow approximately the same structure that Mirza did for Europe as a whole. And then, Stefan, you will then later on present some additional data from Poland. I'm not sure how you pronounce your name. I see you have the same letter as Łódź. I've been in Łódź. So could it be something like Boguszławski? No. How do you pronounce your surname? I have to be correct.
He's muted.
You're muted, Stefan.
Okay. Well, I guess that eventually...
you're perfectly correct.
It was perfect, yeah. Well, I have a difficult name as well, so no one can really pronounce it. And it's Terje Andreas Eikemo, and it's a Norwegian name. I'm based in Norway at the Norwegian University for Science and Technology. And you, Stefan, you are the deputy head at the Department of Population Health Monitoring and Analysis at the Polish National Institute of Public Health. I think I'll just start off by presenting the Polish results. I hope you can see this. And so here you can first see the same overview that you've seen earlier. And we've tried to mark off Poland here as well. As you can see, Poland is placed around the European average. It is not ranked perhaps at average, but it has an average level of self-reported poor health. And the overall levels, they have decreased of poor health, decreased substantially from 2014 till 2024, which is good news. But then we can also see that the original levels that Poland had were also very high. So the potential for improvement was actually quite high as well. And Poland ranks among the 4 countries with the highest health gains, together with Slovenia and Portugal and Hungary. And if we go into the underlying reasons for this, now we will show a slightly more complicated figure, because here we can see that there are declines in average population health levels of poor health in all education groups, but more so among the lower and mid-educated. So if you look at the graph carefully, you can see a blue line and a red line. Now, the blue line shows the results 10 years ago. It goes from low education to high education. So the fact that the curve goes down means that the higher educated report less levels of poor health. And the same trend can be seen for the red dots, showing that the situation has improved 10 years later. But still, there are differences between levels. But we can also see that the health gains have been different across groups. So for the low educated and mid educated, we see that the health gains have been more substantial than for the high educated. And that, of course, means that the relative inequalities have, so to speak, increased. And these are the reasons. So if you look at the next graph, it shows the changes in the relative risk of inequalities between the higher and the lower educated. So, and why do we place Poland on the bottom? Well, it really refers to the results we saw in 2014. So the blue dots shows the level of relative inequalities in self-reported health between education groups in 2014. So in 2014, Poland had the largest relative inequalities. So when you see countries that has the red dot on the right side, it means that the situation has worsened. If you see, like in Poland, that the red dots are on the left side, it means that the relative inequalities have decreased, which is good news. And as you can see, the relative inequalities have decreased quite a lot. But then the reason is, of course, that the health gains have not been as substantial for the higher educated as they have been for the lower educated. So those are the underlying reasons for that. And then we can go on to the next graph. That should be mental health. Let's see if that's the correct one. Exactly. Now we go on from poor health to poor mental health. Also in the same age range, 25 till 75. And also here we can see that there have been improvements in the reporting. So the levels of self-reported poor health in 2024 have then changed by approximately 4 percentage points in Poland, from 17%, 17% in 2014 till about 13% in 24. And if you wonder what poor health means, it is very difficult to ask people about their mental health, so we don't rely on only one question. This is a summary of several questions that asks about feelings of depression, efforts, restlessness, happiness, loneliness, enjoyment of life, sadness, and motivation. So, and this made an additive scale from 0 to 24, where higher scores indicated a higher risk of poor mental health or depressive symptoms. So if anyone reported symptoms most of the time or almost all the time, we assumed then that they reported poor health levels. And what about the differences? Because we see here that Poland is also on a European average. with its improvements overall. And if we look between socioeconomic groups, and now we go on from education till occupation, we see that the situation has improved from 2014 and 24 in all occupational groups. But we also see here that the health gains have been bigger among the higher occupational groups. And this has then resulted in these relative differences here. And in 2014, Poland was the second best ranked countries in terms of this magnitude of relative health inequalities in mental health between occupations. Only Austria was better. And because the red dot is now on the right side, it means that the situation has worsened. But of course, the situation among all occupation groups have improved, but they have improved slightly more for those with the highest occupational situation. So that is why we have seen a slight worsening of the relative inequalities in Poland. So if we can make then some key points, we could have made many. We see that overall levels of self-reported poor health have declined substantially. That's a key point in Poland. But they have not declined very much among the higher educated. The second point is that Poland now has, on average, health levels that are on a European average, both for self-reported mental health and self-reported poor health as well. But this is because there are a few countries that are much worse off. So that is why Poland is on an average. Poland does not rank average, but in overall health levels, it is around the average. The self-reported poor health, this is the third point, has slightly improved for everyone, but more for higher occupational groups. So overall health improvements in mental health, but more so for those with a higher occupational positions. So so in summary, I think this shows that Poland has, at least according to the data, had progress, but this progress has been, there are underlying socioeconomic differences here that highlight that not everyone has gained equally, according to both education and occupation. I think that now in the next presentation, Stefan would go into the more into depth on Polish data to see if we can find some explanations for these trends. But as you hinted, Stefan, you may you incline that perhaps the situation is not as positive as these results have highlighted. But we also have to remember that this is, here we look at Poland comparatively across Europe. So perhaps you are not doing as bad as other countries are from a comparative perspective, even though there are some details within Poland that you would like to highlight more, where the situation is not as good as we might have thought. So I'm going now to take down my presentation, if that is possible. Let's see. There are so many windows here.
I can share probably my presentation and it will automatically. Okay, let's see.
Do I need to stop sharing somewhere?
Just stop sharing. It's up on the screen.
On the top right, it should say stop sharing.
Yes. My name is Stefan Bogusławski, and I'm a medical doctor. I'm working in the National Institute of Public Health in Warsaw since 2018, and before I had a long career in the market research and consulting industry. So I really changed from the business to the science, and it is really exciting. And I am very pleased to be participant in this interesting and inspiring event, the publication of the Social Inequalities in Health report prepared by EuroHealthNet office. And the reason why I'm happy is that the topic of the report is very close to me. I believe that health is of great importance for maintaining the development and stability of social economic systems in the period of turbulent changes worldwide. So I think we are now in the right place, in the right moment to talk about the right things. And now I share my presentation. I hope you see it.
We can, if you just click presentation view.
Yeah, I'm just doing this and should work now. Yeah, okay.
Perfect, yeah.
Yes. So my task today is, in a sense, to comment on the research results described in the report concerning Poland. And I thank you very much, Teria, for your introductory comments. And to be honest, I can already tell you that it is very difficult to comment why it is relatively so good in Poland compared to the other countries, because there are many reasons of the differences, and they are not always as positive as we in Poland would like to see them. So I would rather comment on the recent trends, as I think we have as you will see, we have a kind of trend break or trend change recently. And yes, the recent trends somewhat differ from what you have observed. My presentation is based on the report published this year on health status of the Polish population and its determinants, which is basically biannually published in Poland. A thick book with a lot of data, and it is in English. If anybody would like to refer it to it, you can find it on our web page. This product was financed by the Ministry of Health and within the framework of the National Health Program. Okay. First of all, the starting point. We had a long-term growth of average life expectancy since Poland regained sovereignty and changed its social-economic, social-political system. I think the country was a very good example of very positive trend in terms of the population health. If we consider life expectancy as useful and appropriate indicator to describe health, then it must be acknowledged that from 91 to the middle of the second decade of the 21st century, improvement of this indicator was truly impressive. There are certainly many reasons for what happened here, but there's no time and no place, not a good place to discuss it today. What I would like to draw your attention to is the fact that from around 2016, we have observed significant slowdown in the increase of the life expectancy, which we may describe as close to stagnate. We had, of course, had excess mortality during COVID-19 epidemic, which disrupted the trend. That's why we are eagerly waiting for the research results for 24 and 25. Because we will see to what extent we have to adjust to the new pre-pandemic tendency. This phenomenon of stagnation is somehow confirmed by recent social surveys. We run this kind of social survey based on 3,000 respondents, adult people, every 2 years, which shows the visible deterioration in adult self-assessment of health, with growing share of the people describing their health as poor or bad or very bad, for women from some 7 to over 10%, and for men for more than 5 to 10%. And we also see a vast increase of the share of the respondents declaring long-term burden health problems. This is an increase about 50%, 25 compared to 2018. Moreover, we see that quite substantial shares of respondents declare symptoms of moderate or severe depression. It is almost 1/5 of the population, and about 1/5 of the population declaring symptoms of generalized anxiety, which may be also related to the, as I say, the kind of turbulent times we live now. It is therefore clear that we are dealing with a worrying trend. Before it was good, now it's not that good. So we have to look at the reasons for these differences and the reason of the change of the trend. It's not only the health status, but also the health determinants that we have to look at, as you will see. First, I have to admit that we know that Poland's life expectancy, which is lower than EU average, is associated with excess mortality among men in all age groups and among older women. And that excess mortality is undoubtedly linked to the broad phenomenon of inequalities in health and its determinants, which hinder increases in healthy life expectancy and life expectancy in general. A legitimate question is, okay, yes, a very interesting observation with which I would like to start is that the finding that predominant causes of premature death are those avoidable through prevention, and to a much lesser extent, those available through treatment. I would say that this slide alone tells us that we have to look at the health determinants more than healthcare resources or the access to the treatment, which doesn't mean that access to the treatment is unimportant. It is extremely important also in Poland. But I think prevention is really the key for the solution. I will present you two examples of concerning phenomena. These are, of course, arbitrarily chosen, but I believe that they illustrate well the situation in many areas of public health. The first example is truly striking. It describes life expectancy depending on education level. It turns out that less educated people in Poland live significantly shorter lives than better educated people. This difference amounts to as much as 13 years for men and 9 years for women between those with primary education and those with a higher education. It's a truly big gap. Clearly, this observation alone doesn't give us direct guidance as to what actions should be taken, but it is certainly a very strong premise for further analysis and for defining causal relationships leading to this phenomenon. A further deepening may be an analysis of potential life years lost, PYLL, due to different causes of death. For men, I choose for such causes that illustrate large PYLL losses. It is not surprising that the dominant causes are cancers and cardiovascular diseases. It's probably small in the most other countries, but it is important that to note that significant PYLL losses are due to alcohol consumption or suicides. These data already indicate the directions of necessary analysis and actions in social and health policies. As you see, it's together 15% or 16% causes related to alcohol consumption and suicides. Further analysis shows that risky patterns of alcohol consumption are definitely more common among men with lower economic status. This is the graph on the right-hand side. And it is related, it is the same, not the same scale, but the same phenomenon both for men and women. And this particular observation indicates really very concrete directions of action to reduce the negative effects of alcohol. The second example is based on analysis of potential years of life lost among women. In addition to cardiovascular diseases, the dominant causes are cancers, especially breast cancer and respiratory tract cancers. At the same time, the geographical regional disparity in women life expectancy is huge. It is 6.5 years between the best and the worst regions. As you see, this is the description, a visual description, graphic description of the differences. It is also gives the kind of space for improvement which we potentially have. There are many causes of that situation, but to one I would like to draw more of your attention. It is to highlight the very high prevalence of reported overweight and obesity among women in difficult economic situation. And this is really a very difficult situation. For women with no economic difficulties, the prevalence of obesity is close to 10%, and with economic difficulties, it is over close to 22%. And it is the obesity as such is, of course, is source of various diseases and consequently shorter life expectancy. But it is also an indicator of negatively acting behavioral determinants of various types, which ultimately lead to more frequent occurrence of cancers. My task is also to describe somewhat at least the actions we are taking in our country to restore and sustain the previous long-term grant. When I compiled this list, by the way, it is not complete. I was surprised of how many of such activities are underway. They include sugar tax, which is being already implemented, national disease prevention programs, several programs, including cancer and cardiovascular diseases, but not limited to these diseases. Particulate matter emission control programs, which in many places of the country are very successful. National transformation plan optimizing healthcare resources, restrictions on smoking and substitutes of tobacco implemented and developed already for years and modified for years. Recently introduced non-mandatory, unfortunately, non-mandatory school health education lessons for children and youth 11 to 18 years old. Alcohol advertising ban and availability restrictions, which is now a subject of very heated discussion in the country. Really, it's really in the in the center of the political life, but of many other. And also new national health program 27 to 31 with development of where we plan development of methods of assessment of the effectiveness of public health interventions. This was my last slide. My last slide. I remain of course, I'm looking forward to the discussion. Thank you. But of course, I have to say that the presentation was possible thanks to the work of entire team of our department. Thank you very much.
Thank you, Stefan. I already provided a question in the chat, so people could have already provided comments. I see that Dorota is mentioning that there is also the reform of mental health care system, especially with regards to pediatric mental health services in Poland. That should that could be added as one of these.
Sure.
I mean, if the audience here, I mean, you can continue to provide comments, questions in the chat, or you can also turn on your camera and present to us your questions in person. If not, then I suggest that Stefan and I will have a discussion on our own, because we will be doing a summary of the session afterwards. My own reflections is that some of the results we've seen in the report are actually supported by the evidence presented here. For example, the increases in life expectancy. I mean, there have been declines during COVID, there have been stagnation, but if you look at the full period from 2014 till today, there has been an increase. Of course, there are variations within this period, but what is not supported, what does not support our report, are the results from your survey showing that there have been declines in self-reported health. Of course, that forces the question, on how the measures were actually. So were the same questions asked? Was it harmonized across time? And do the questions correspond to the results of our report? I think that could be an important question here. So why do you find something different in your survey than what we find in the European sources survey? Can you reflect on that? You remember the questions?
Yeah, of course, yes. We actually profoundly discussed that phenomenon, and our answer is that actually the periods are different, because we compared to 24 to you compared, or EuroHealthNet report compared 24 to 2014, and our survey compared 25 to 2018. And that 4 years actually also, these are the 4 years when we started to see the kind of stagnation of the healthcare. And actually these differences are subtle, I would say. So I wouldn't say that these results are really contradictory. I mean, in 10 years time span, I think that observation that there's an improvement might be absolutely correct. In the same time, as I say, we have different period, plus we had a kind of recent phenomenon of pandemic. So yes, I think it is understandable.
Yeah, there is an important question here about the migrant situation. So whether they have been Ukrainian migrants, whether they have been included in the analysis.
The answer is not. But yes.
And for the European Social Survey, I would assume that the answer is yes. But the thing is that we don't do oversampling, so there would still be a relatively small proportion of the full population. So we wouldn't be able to. It wouldn't be able to affect, I would assume, and depending on how many migrants you actually have. But this is a question that I'm not the most. I'm not the expert on that. I will have to look into this Polish data and see how migrant status has been measured and whether Ukrainians are included and whether the sample corresponds to the population. But migrant status is something that the European Social Survey takes really seriously. So.
This is really completely new.
Because of the slight delay before the case study segments.
We have a hand up from Anna.
Yeah. Yes. Please go ahead with the question.
Hello. Can you hear me well? Can you see me well? Perfect. Thank you so much. My name is Anna Kavaras, and I'm a Ukrainian migrant living in Poland, implementing projects in public health system in Poland from National Health Fund. Thank you very much for this very important discussion for me on a professional and, of course, personal level. My question is related to self-assessment of adults' health. And so self-assessment is a very tricky, right, in terms of methodology. So the fact that certain numbers actually say that the level of their health, judging by the self-assessment structures, is deteriorating, don't you think that it might be slightly related to the fact that the general awareness of health states and health education is much better these days, right? It's also achievement of public health efforts. So that's my question. And the second question is like taking that into account, how do you assess the margins of error in this kind of research? Thank you so much.
Yeah, so but you're right. Self-rated health is not an epidemiological measure. It is a self-assessment, and it's a holistic measure, and it captures health more broadly, and it really takes into account the social, economic situation that people are in, and including the services that are accessible to them. And you also even know that in service, people tend to report differently according to which questions were just asked before the question on self-assessment. So yeah, it's there are enormous limitations when we think of this in medical terms, but as a social measure, this is quite valuable. And we also know that the correlation to mortality, the prediction of mortality of self-reports is extremely high. So if you ask people if they have diabetes, if they had a heart attack, and if you ask them what their self-rated health is, then this measure will be the strongest correlator to mortality, because people are really aware of how they are, the economic situation they live in. So it's much more than health. And uncertainty measures, yes, there are these are standard uncertainty estimates, as in regression analysis with confidence intervals and 95% confidence intervals, which are not presented in the graphs, but are presented in the full report, I would assume, with confidence intervals. Yeah. So I think there is 1 minute left. So either are we kicked out, or will we have to? We probably have to press the link again, right, Chris?
We have. I put in the chat. I put the original link, but that's
Okay,
how you go back
so
to
everyone
the original
press
plenary,
on that link. I suggest now there is I would love to continue this discussion. And I
Thank
hope
you so
that,
much.
yeah.
Anna, please feel free to contact me directly. I think you can
Sure.
find to
Lovely.
the page. Okay.
Thank you so much. Will do.
I think we are waiting for one more group to finish, and then we can start. I also see that Professor Sir Michael Marmot has joined us. Great. So he will be able to also listen to the feedback of the 4 breakout sessions. It was very rich information again. There's a lot happening in the countries, and a lot of great policies and initiatives, and thoughts also how to proceed on the different governance levels and in the different policy areas. But I'm very keen to hear from the countries. So we take the same order as in the agenda. So I would like to start with Poland, and I hope that Terje already is in the room, and I would like to give the floor to Terje to report from Poland. Terje.
Hello, everyone.
Hi.
It's good to be back, to see you all again. Yes, so we had a really nice breakout session discussing the Polish results. And for those of you who don't remember exactly the Polish results, they really show improvements in terms of overall self-rated health and mental health, placing now Poland on in average in Europe, but also that there are important differences between occupational and educational groups, and that are important and are showing that the higher educated are not improving as much as other groups, while in terms of mental health, the higher occupational groups are doing better than the other groups, showing increased inequalities. So overall, I think these are nice developments, although with some nuances. We had a presentation by Stefan, who could tell us that these results are supported also in Polish data. So there have been increases in life expectancy over the last 10 years. But also they did their own survey, their own social surveys, showing that there were increases in poor health during the same period, which somehow shows a contradiction to our results. But then we figured out that the period was not exactly the same. Now I hear my own voice.
Yes, there is an echo right now.
For everyone.
Yeah, no,
it's gone.
it's good. Yes.
Yeah. Well, it's good to hear myself twice, then I can have repeated what I'm saying. So why do we see what we're seeing? It is difficult to pinpoint on different things. There have been actions in Poland in terms of healthcare, alcohol, sugar taxes, so different reasons for these improvements. Of course, we cannot connect them directly to the data, But also, it will highlight that not everything is great. There are reasons to concern as well, and but from a comparative perspective, we do see that Poland is improving its situation, and I think that we can learn from all countries can learn from all countries in terms of certain aspects of our findings and the policies that have been implemented. There are also questions during the session, for example, in terms of the Ukrainian migrants and how that might have affected the results over time. The European Social Survey does include migrants in the study, but proportionally this is a low part of the sample. So it's I'm unsure how much that has influenced the results. But I should also mention that that ESS does have Ukraine in some rounds included separately as a country. So it would be possible for those who are interested to go more deeply into Ukrainian data, although Ukraine was not included in our analysis. So I think that that wraps up what we touched upon in our session.
Yeah, very interesting. Thanks a lot, Terje, for the reporting back. Next is Austria. So we go to Austria and to Anne Wagenfeuer-Leroyer, program manager at EuroHealthNet as well. You have not yet seen her, but Anne, if you can go online and share the results from Austria.
Yes, thank you very much. So Austria is also a very interesting country in terms of self-reported poor health. The levels are relatively stable. There's a slight decrease of poor health, which is of course a positive, but this is only the average. And what the Austrian data shows very clearly is that Austria is actually the country with the highest increase of inequalities. So this apparent stability in terms of the average actually hides that only the educational groups that are mid-education or higher education have improved their health, and lower educated people actually suffer from worse health. And so the average is the same, but the inequalities have grown rapidly, and someone with from the lower educational groups is in 2024 3 times more likely to report poor health than someone from the higher educated groups. In terms of mental health, the picture is a little bit different. Austria also shows that there has been a slight improvement in terms of mental health across all occupational groups in this case. So this is of course very positive. But from those who benefited, who benefited the most, it's again the higher occupational groups, meaning the white collars, that benefited most from these mental health improvements. So in general, a slightly positive trend, but higher inequalities there as well. Then our colleague Marion Weigel from the Austrian National Public Health Institute show to the very nice example of Frühe Hilfen, which is an early childhood prevention program, and showed some data there as well. They managed to really reach lower socioeconomic families very well. The numbers have increased over the past years, and they manage especially to improve the situation in terms of administrative burden, medical needs, social needs, etc. Very interesting data. And our discussion focused a little bit on mental health measures for families in this program. Also the topic of unpaid care, which is a very important topic. There were questions about how to disseminate this program well. So a very rich discussion, and I thank my group again for this very nice breakout session. Thank you.
Excellent. Thanks a lot, Anne, for the reports from Austria. Now we go south to Spain again, and I would like to invite Ingrid to give a short feedback. Ingrid.
Yes, we heard about Spain again. So, and this time we also dove into the situation on health inequalities in Spain, and it's a positive or a story with positive and more negative sides. Maybe to start with the somewhat more negative. Well, the positive side is Spain has the highest levels of life expectancy in Europe, but then we see that when it comes to self-reported health, it is actually amongst the lower performers. So I think that may also have to do with the fact that healthy life expectancy is kind of mid-range in Spain compared to in other countries. And self-reported health actually declined in Spain over the last 10 years. That decline happened, Caroline, as you were mentioning, mainly, it's one of the examples where it was mainly amongst the middle socioeconomic groups. The positive part of this story around poor mental health is that Spain has the lowest levels of inequality in poor mental health. And those levels of inequality actually, even though health as a whole declined, health inequalities remained stable. And for mental health, we actually saw a slight increase in levels of mental health. So that's, again, part of the positive story coming from the data from our survey. But in this case, there was an increase in the lower and the middle groups, but a decrease amongst the higher educated groups. So in our definition, this doesn't mean it's not a success story in terms of leveling up the health gradient, because of it wasn't leveled up across the board. Although inequalities, again, in self-reported mental health are quite comparatively low in Spain. But yeah, following the presentation, there were a few questions just on the data and the evidence from Spain, a few questions, mainly, or comments, mainly around the mental health results, because national surveys in Spain show something different, that mental health is also declining. So there was a question around why could this be? And it could have to do with the fact that our data was focused on 25 to 75-year-olds, while we know that in those outer ranges, mental health, well, amongst youth is declining in general. So, and that was confirmed by Anna and amongst older populations. And then we heard again from Ana Gil about some more initiatives, more surveys that are being undertaken, but particularly also about this tool that they've developed on health equity strategies and programs, a tool to analyze different health, public health programs and to equity check them. Yes. Because I think it's very important to keep first and foremost own a house in order before looking at other policy areas. So Anna shared what that tool was and some experiences in also applying it just to improve the quality. That's the main the positive contribution of this tool.
Exactly, yes. Yeah. And we have included more information about this tool in the report as well. So with links if people are interested. Thanks a lot, Ingrid. It shows how complex inequalities can be, when we look at health, mental health, and the different groups. But thanks for giving that nice overview. Last, we go up north to Norway, and I'm happy to give the floor again to Mirza. Mirza, floor is yours.
Thank you. Thank you, Caroline. We had, I think, a very good session. Also, a lot thanks to Øyvind's intervention. I briefly shared the results we had for Norway. In Norway, compared to 10 years ago, we have lower levels of self-reported health and significantly lower levels of self-reported health. Comparatively, Norway is still among the best performing countries in Europe, but compared to itself 10 years ago, things are not going as well as we would have believed. And at the same time, we have increasing levels of inequalities in self-reported health in Norway. So this is particularly important because the Nordic model is what we propose very often in terms of how we should improve access to education and create incentives, and how we should protect financially our more disadvantaged, and how we should lower poverty rates among children. And then when the model itself it's not delivering as we expect, then this calls for trying to improve that model, because we all need a roadmap of how things can be done better and how we should invest in our society and how we should think our economy is for our society and not our financial systems. So And that was the good news that Oyvind shared with us, that first of all, they are aware, also their data were showing the same patterns, including also for mental health, which I didn't mention so far, because I really want to highlight that in Norway, now there are quite some initiatives worth following to see how the model can be improved, because there is, after so many years, a new strategy as well for health, and the strategy is called the National Wellbeing Strategy, which has been launched in 2025, and I hope we'll have opportunity to read some part of it in English and to learn what their design is, what their thinking is behind it. There are also some changes in acts, national acts, to increase the responsibility for public health among the national authorities. Because as Eivind rightly pointed out, like inequalities are not a matter of just a country. They are very visible at your local level. And he showed very nicely that the inequalities in self-reported health in Oslo are as wide as among neighborhoods of Oslo as they are among countries in Europe. So the need really to tackle it is very visible, it's very present. And these strategies are actually a positive message that with the right political capital behind it, with the right political will, things might be at least planned to get back on track and improving. And that's why I invite everyone interested in health inequalities to see what's going to happen next in Norway and follow this initiative. Thank you.
Thanks, Mirza, also for your feedback from this session. Indeed, very rich, and it also shows how we need to target and make our approaches really, I wouldn't say personalized, but yeah, targeted to the different levels of governance, the different problems that are there, and indeed keen to see how Norway and other countries are moving forward on trying to reduce these inequalities in health. So thanks, Mirza, and thanks to all the speakers from the sessions, from the country sessions. Now I'm just looking at the time, and we have 8 more minutes to go, and I hope you can stay a little bit longer because we have Professor Sir Michael Marmot with us today, and he was also with us yesterday in Brussels in the European Parliament. And I'm really happy to give you the floor as our final speaker to share your reflections with us, Professor. So the floor is yours.
Thank you. And it was a great pleasure to be with you yesterday for the launch of this report. I say it's a great pleasure, and it was, but the results in the report are alarming. They are alarming. In many countries, physical health, mental health deteriorating, inequalities getting bigger. It's a mixed picture across Europe, but one doesn't look at this and say it's wonderful. I remember Amartya Sen saying that an optimist was one who thinks the present organization of society is the best that could possibly be. And a pessimist fears that that may very well be the case. My version of this is slightly different. A pessimist says things can't get any worse. And an optimist says, oh, yes, they can. I want to come back to the question of optimism and pessimism, but we can't look at these results with equanimity. Action to do something about it can take place and perhaps should take place at local level, at national level, and at supranational level, European, global. At local level, as I mentioned yesterday, we've been very active in the UK on Marmot places. There's long-standing tradition of WHO Healthy Cities program, but the Marmot places build on our 8 principles. And there's a negative and a positive reason for acting locally. The negative reason is if national governments aren't willing to act or don't know what to do, then we need to get action locally. The positive reason is there's real commitment locally from local government, from the voluntary and community sector, from the health and care sector, for the police, education, fire and rescue. We've got all these bodies really committed. At national level, we have to think about the gradient right across, not just poverty. I was talking with colleagues yesterday after our meeting in Brussels, and I said that the data show in the US and the United Kingdom, overall income inequality hasn't changed much since the global financial crisis or even before. What has changed is if you look at the ratio of income of the top 1% to the median, that's increased enormously. If you look at the ratio of the median to the bottom 10%, that's declined. In other words, the top 1% are pulling away from the rest. Perhaps one of the most telling slogans, political slogans of the last many years is, we are the 99%. The top.
I think there was a drop in the connection there he is.
I had an error
I
message.
thought it was me. Yeah, I thought I was blocked here, but yes.
So what I said before I got the error message is the median income is starting to look more like the poor. And that means we have to make common cause between people living in poverty and people living in the middle who aren't doing really very well. We heard yesterday in Parliament a familiar refrain. What about freedom? Taking action will erode people's freedom. And I was reminded of Isaiah Berlin comment. Berlin said that freedom for the wolves has very often meant death to the sheep. It's all very well to privilege freedom, but freedom for whom? And under what conditions? A freedom for the wolves has very often meant death to the sheep. If we want everybody to enjoy freedom, then we have to take social action. We have to create the conditions for everyone to enjoy freedom. At supranational level, European or global level, I mentioned yesterday that I am co-chairing a council that UNAIDS set up on inequality, AIDS and pandemics. And one of my co-chairs, Joe Stiglitz, Nobel Prize-winning economist, is chairing a committee on inequality for the G20. South Africa has the presidency of the G20 this year. The United States has it next year. Goodness knows what's going to happen to the G20 next year. Brazil had it, and they were very active and impressive, as is South Africa. We hold our breath at what happens when the US takes it over. But Joe Stiglitz is chairing this committee on global economic and inequalities, income and wealth. And I have urged him to take on board inequalities in health. I said in the draft, they don't mention health. I said that, all right, I would argue this, wouldn't I? But I would argue that health inequalities are the worst result of inequalities of wealth and income. That if you're going to be concerned with wealth and income, you've got to be concerned with the effect on people's lives. And the way we see that is inequalities in health. And I think that what we are doing, we who are concerned about how social conditions lead to health and health inequalities. We are contributing to a debate on what constitutes the good society. Joe Stiglitz's latest book, The Road to Freedom, he talks about what's needed in a way that would be very familiar to those of us in Europe who want social democratic principles, create a learning society, a rich ecology of institutions, public and private, rebalancing power relations away from the top 1%, the techno-feudalists who are controlling, putting social justice and inequalities at the heart of what we're trying to achieve. I said miserable things about optimism and pessimism. I said I wanted to come back to it. I've been thinking a lot lately about hope. A Brazilian colleague said to me that when I said I was an evidence-based optimist, he said, "You're using the English language incorrectly. You're not an optimist," he said, "you're hopeful." The difference being is that an optimist knows things are going to get better. Optimism is the opposite of fear. It's based on the opposite of pessimism. It's based on certainty. Hope is the opposite of fear. And the importance of hope is that we don't just sit back and watch as things get better or get worse. We take action. We join together. And I was thinking about this when I was giving a lecture in Northern Ireland. So I pulled out an Irish poet, Seamus Heaney, and he says, "History says, don't hope on this side of the grave. But then, once in a lifetime, the longed-for tidal wave of justice can rise up, and hope and history rhyme. We can say that things are going terribly, and in fact, history and fear are rhyming. We have to take the action to make hope and history rhyme." Thank you.
Mm-hmm. Thanks a lot, Professor Michael Marmot, for your very inspiring words. I mean, you have been a real champion for all of the work on social inequalities in health, and it was a pleasure to have you here to share your insights. It's very much a call to continue to work on the underlying structural determinants of power inequalities, as you said. I think we need to go more there. As far as we can, and but also your words of being hopeful and being an optimist, and that's what binds us all together, because this is the way forward. And I think with the report that we have launched yesterday and today on social inequalities in EU, I think we've managed very well to keep also this movement alive on working on health inequalities. And I think it's a powerful call for action. And I would really want to thank all of you present today. And I would like to invite all of you to join our call for action. What EuroHealthNet will be doing in the coming years is we will work with our members to take a few countries per year to dive into the situation per country and to gather people together to work on the evidence further, and also to connect it to some of the EU policy processes like the European semester that also does country-specific recommendations, which is then linked to funds. So there are definitely very nice opportunities at the EU level to work on this with our members. And this is also a call for you present here. If you would like to join us on this work, then please do reach out to us. We would really want you to do so. Right, we are now coming to the end. I would like to thank all of the speakers for today and for all of the participants to stay with us until the very end. And I would also really like to take this opportunity to thank the team, the EuroHealthNet team, to make this all happen. It's not only this webinar and yesterday events, but also the report and the design of the report, the communications, and all of the organization of the past months and weeks. So a big thanks indeed to Ingrid, Ans, Mina, Sylvia, Chantal, David, and Chris. Clearly also to Mirza and her team and Terje and all other EuroHealthNet staff that is supporting us as well throughout the last period. So thanks for all of you being here, and I wish you a good afternoon. Oh yes, and if you have specific questions for Mirza and Ingrid on some of the data, we can hang on a bit, so please feel free to stay and we can have a chat. And for all the rest, bon appétit.